Welcome back to the second day of our webinar on strengthening primary healthcare. For those of you who are just joining us today, my name is Bob Phillips, and along with Linda McCauley, my co-chair of the National Academies Ad Hoc Committee on Implementing High-Quality Primary Care, we produced the report, Implementing High-Quality Primary Care, Rebuilding the Foundation of Healthcare, which is the progenitor of today's webinar about how that translates into an implementation plan at the federal level. This webinar is a collaboration between the National Academies and the Office of the Assistant Secretary for Health's primary healthcare team. It is also a collaboration between people on this webinar, the external and internal stakeholders, frontline primary care clinicians, leaders of primary care, and the agencies of health and human services about how a Secretary's Council or Office of Primary Care can shape primary care strategies to address the nation's health priorities. So yesterday we heard presentations and discussions on what is the desired model of primary health care. And it was kicked off by Merritt Felsian, a patient advocate, member of a patient dietic team in Eastern Colorado, who gave us some incredible insights about the importance of not only primary care, but high quality, comprehensive, curious healthcare teams who build trust over time. And it harkened for me back to the patient group that informed our report, who described primary care as the place where you go when you can't go anywhere else with your health concerns, because that's where your trusted relationships are for health. And they described very explicitly other things that were discussed yesterday, like the need for process measures about, did you ask the patient and caregiver what their goals for the day are? And another process measure, how is the care designed to help achieve those goals? We heard a lot about that in yesterday's second group discussion about how we measure primary healthcare for value, impact, and investment. And then we heard yesterday about innovations that the federal government could consider to strengthen primary healthcare. If you couldn't join yesterday, the presentations will be available on the National Academy's website, but I strongly encourage you at the very least to watch Rear Admiral Rachel Levine's opening and Dr. Judith Steinberg's closing. It was an excellent summary of the day's key messages. Today, we will hear discussions on what successful state innovations look like and how can a federal leadership support and spread them. We'll hear about activities that are advancing health outcomes, access, and equity through primary healthcare strengthening in states, territories, and tribal nations. Wonderful examples that could be replicated to address what are now growing health disparities in the United States. We'll hear about how state-federal partnerships can improve health outcomes, access, and equity by strengthening primary health care. So this is not just about a new federal primary care strategic capacity, but also about how that capacity can support similar strategic state efforts. We'll hear about changes that are needed to support health professionals and communities' engagement in strengthening primary health care. As an example, the U.S. Department of Agriculture, which has a ground game in every single county of this country, how it has revolutionized the speed at which we improve farming in this country and how that potentially can inform what we need for healthcare. And finally, we'll close with how Health and Human Services can respond to the challenges discussed yesterday and today. Again, the aim of this workshop is to inform the initiative to strengthen primary healthcare as it creates recommendations to the Secretary of Health and Human Services for a federal primary care council or office that coordinates primary care strategy in the service of our nation's health priorities. Before we start our first discussions of the morning, though, to the audience, I want to remind you, we really want you to participate. So please submit any questions via the Q&A function and include your name and affiliations. The webinar is being recorded and we'll be archiving this online after the webinar. Also, please note that we are somewhat dishonoring our speakers today by truncating their introductions, but their full introductions are going to be available on the project website and are already. So now I'd like to hand it over to Dr. Shannon McDevitt, who is the federal partner lead for the Health and Human Services Initiative to Strengthen Primary Healthcare, and she'll be introducing our first panel.
Thank you, Dr. Phillips. I am Shannon, and I'm a family physician. I serve as a physician in the Office of Policy and Program Development in the Bureau of Primary Healthcare at the Health Resources and Services Administration. And it's my honor to serve as the federal partner lead for the HHS initiative to strengthen primary healthcare. This first session today will focus on what successful state innovations look like. We'll hear from two speakers. Our first speaker is Howard Haft. Dr. Haft is a primary care internist with 48 years of clinical experience, and he currently serves as the Senior Medical Advisor in the Maryland Department of Health and the Maryland Primary Care Program. Dr. Haft, the stage is yours.
Dr. McDevitt, thank you very, very much. I appreciate the opportunity to be here today and be able to present to this very important group some what I think is some hopeful information about public-private partnerships that can produce some of the early fruits of the labors and deliberations that have gone forth in the past. So it's a great pleasure to be here and tell you about the Maryland Primary Care Program and some early successes that we're showing with based on much work that was done by many people in the past. Let's go on to the next slide, please. To provide some context for the Maryland Primary Care Program, this program was developed after 3 years of stakeholder input and work together with our partners at CMMI to produce a statewide program as part of the overall Maryland Total Cost of Care contract. It launched in 2019 and now is in its beginning its fourth year of operations. Looking back at the first 3 years, we know that we currently have 545 practices across the state. You can see those red dots on the map here, which represent the practices. The size of the dot more or less represents the size of the practice, the number of providers in those practices. You can see also that it's sparse in the far east and the far west of our state, which is where we find sparse population densities also. Since its launch, it's grown 43% in terms of number of practices. Number of providers has grown approximately 40%. We care for about 374,000 fee-for-service Medicare beneficiaries in the program, although it is a multi-payer program which now enjoys Care First, our largest commercial payer, as an aligned payer, and beginning in 2023, also our Medicaid program for the state. We serve about 2/3 of all Marylanders currently, and as all of these programs, this is a program that is agnostic as to payer type in terms of the transformation for care. We also include 7 of our FQHCs, which represents 44 sites across the state as part of the program. And part of our intention all along was to continue to add additional FQHCs. We still have 2 more years of open enrollment and anticipate the program will continue to grow during those 2 years. So that's the context. It is a very broad program all across the state that is joining together primary care practices for a unique and special purpose. Let's go on to the next slide. So the purpose is really to get a group of opportunities together and do some specific work that we think is really important. And this is building on work that's been characterized for many, many years as patient-centered medical home and characterized as part of the CPC Plus and the progenitors of that program really describe really important things that needed to be done in transformation of a primary care practice. And just to highlight a few of those, and this is really the same framework very much as we saw in CPC Plus and the progenitors. Access and continuity really important, including telemedicine, which became extraordinarily important during the pandemic, but also making sure that every person understands who their caregiver and their team is. And this program is built entirely on team-based care. Care management was ever so important throughout all of the things we do. And care managers are clearly a central part. Boots on the ground care management in each and every practice. Comprehensiveness of care and coordination are also key to the work that needs to be done within these practices. And part of that has to do with, very importantly, behavioral health integration, particularly looking now that we're still in a pandemic with opioid deaths. Even we see this COVID pandemic hopefully fading away, making sure that the majority of our practices have implemented workflows that address that with expert and also introducing collaborative care and making sure that each and every practice is doing social needs screening for their patients and being able to do referrals to community-based organizations. Importantly, again, patient family advisory councils, as we heard yesterday, without the voice of our patients giving us information about what's important in their goals, we really missed the point. And that was hardwired into this program, that each and every practice is doing patient family advisory councils and attending to advanced care planning. And then in terms of data and planned care for health outcomes, this was a key and fundamental part that I'll tell you a little bit more about in the next few minutes for our program, that we were giving comprehensive data that could be used to all the practices in a uniform way across the state, so that it could all be using the same data tools and the same data sets specific for the populations that they serve, but in a coordinated fashion, all driving toward improving the health of the population of the entire state as we drive forward. Now, all of this is a tall order. All of this is things that have been, or these are things that have been around for a long, long time. What we understood from the beginning is that in order to do this work, there needs to be sufficient resources. It can't be done just bootstrapping what happens in an ordinary primary care practice. So together with our colleagues at CMMI and the financial support and federal support that they provide, the state needed to lean in and provide an extraordinary amount of additional support to make sure that no practice was unable to meet these requirements because of a lack of resource, perhaps because of a lack of intention to do that. And we were very careful to say any practices that did not intend to meet all these resources would be excluded from the program. Next slide, please. So what do we do strategically to enhance primary care? What were really the keys? And this was the question that was raised to us for this particular presentation. What was the secret sauce that we thought was essential to make this program successful? And the first was making sure that we had adequate resources for our primary care providers. Part of that is increasing the amount of investment, particularly on the Medicare side, on a per beneficiary per month basis. And we saw the average investment in our practices go up to $62 per beneficiary per month. Is that enough? It represents probably about 7%, 6.5% to 7% of the Medicare investment for the state on a per beneficiary per month basis. Probably not sufficient in and of itself without the other resources that were provided, but definitely a step in the right direction. We knew if we're going to improve the health of the state, that we needed to make sure that we had a broad span for this program, and we had almost 2/3 or around 2/3 of all of the eligible practices in the state engaged in the program, which allowed us to make a major impact across the state. But we also knew that we needed to really lean in heavily with the state's contribution to this program. One of those big contributions was being able to engage our HIE, the State Designated Health Information Exchange, CRISP, which reached out to each and every practice having its own unique dashboard, and the state being able to provide updates not only of the data related to the utilization and claims for their patients, but data that's analyzed and run through AI and machine learning tools to give really actionable information to those practices. Things like the ability to understand which patients are likely in the next 30 to 60 days to show up at a hospital or emergency department for something that could be better cared for by them in their primary care practice, which really helps to focus the care management resources. This proved to be a very, very valuable tool, and one that each and every practice has updated lists every month. Also opportunities along the same line to be able to provide strategic information about vaccination status for patients, et cetera, and to let their practices know when their patient shows up at a hospital or an emergency department or is released for that continuity of care. We also wanted to focus from the very beginning on equity, and we made sure that not only were we delivering information to the practices about the HCC scores, that is their medical risk for their patients, but also delivering the information about what they needed to know about the area deprivation index and the social vulnerability index and their COVID vulnerability index, something we put together during COVID. So all of that the ability to focus on that was really, really important. Now we're also launching into a time beginning this year where we're specifically providing payments to providers to be used for patients who reside in high area deprivation index areas who also have high HCC scores, to really focus on that equity portion of the program. But the other thing that we really leaned in on here was making sure that the practices knew that there was a home for them also in the state, in public health, and that we were able to provide on a regular basis information that came from the state, from the Maryland Department of Health, that could lead them down these paths that were really important for them. This became really important during the pandemic, where we were able to provide tools for vaccination, for testing, for communications, for therapeutics, and everyday population health data information, in addition to a whole range of other educational and leadership programs. So having the state show an interest and develop uniformity for these practices was also really key. And I'll just pause here for a second and think back to a picture that maybe some of you have seen on the walls of your providers' offices, or perhaps you have seen in your office. And that's a picture that comes from the Saturday Evening Post that Norman Rockwell put in 1947, that showed Dr. Russell, who was his family doctor. Painting showed Norman Rockwell's family sitting in Dr. Russell's office with the dog on a chair, and Dr. Russell taking care of the entire family in Arlington, Vermont. It was a time when Dr. Russell was really the public health doctor for Arlington, Vermont. He was responsible for encouraging people to get immunizations, for looking after rabies issues, for making sure there was clean water, and that every aspect of the care for that community really intersected with the work he did. And I think public health and primary care were really born of the same mother. They're twins of the same mother. They were separated for some time, and now are coming together in a way that's really dramatic. Let's go on to the next slide. So what were the results from this program? First, in terms of quality, I think overall, even through the pandemic, the majority of our practices were doing better than 50% level for quality measures that we looked at. We tried to be very focused and not overwhelm them with large numbers, and also align those quality measures with the state's integrated health improvement strategy, largely looking at things that are really important, like diabetes and hypertension, and behavioral health issues. And then also focusing on utilization, and through the tools that we gave the practices, they're consistently better able to reduce avoidable utilization for emergency department and hospitals than their matched cohorts and similar practices. So the tools and the intent that we had here were very effective. Next slide, please.
Dr. Haft, could you provide a summary remark? We're going to move on to Ms. Phillips' presentation.
Yep, sure, certainly. So in the summary remark is what this really shows in the end is that through the efforts here that we were able to show that we saved money on the Medicare side over several years, and produced the net savings even after the investments of over $16 million. And during the pandemic, we were, compared to matched controls, we were able to reduce hospitalizations cases and reduce deaths by 20%. So appreciate the opportunity to speak, and happy to answer questions later. Thank you.
Thank you so much. And if you have questions for Dr. Haft, he'll be joining the question and answer session following our next panel. So thank you for that vision and emphasizing the importance of the integration of primary care and public health so close to all of our hearts. Our second speaker is Catherine Phillips. Ms. Phillips is a senior program officer on the California Healthcare Foundation's Improving Access team, which works to improve access to coverage and care for Californians with low incomes. Welcome. Thank you, Ms. Phillips.
Thank you, Dr. Levitt and Dr. Taff. What an impressive example of care transformation from Maryland. Today, I'm going to share California's approach to strengthening primary care, which is informed by the pioneering work of many other states, most of which are on the call today. And I'll also provide a few examples of the types of federal policy action that I think are really required to support state innovation. My slides are dense and link heavy. Don't feel pressure to read along, but I hope at least a few of you will click through to some of the resources I mentioned after today's call. Next slide. For quick background, the California Healthcare Foundation is a private philanthropy that works to strengthen Medi-Cal. That's California's Medicaid program. It covers 13 million people, nearly 1 in every 3 of our state's residents. In 2020, perhaps belatedly, we launched a new portfolio of work aimed specifically at strengthening primary care delivery in California. And we were motivated to focus on primary care because despite leading the nation in insurance coverage, we continue to see significant problems with access, with quality of care, and with health disparities. In 2019, for example, more than 1/3 of our Medi-Cal members received no preventive care whatsoever. And that's an equity problem in our state because 80% of Medi-Cal members are people of color. We also recognize that our efforts to implement evidence-based care models like team-based care and advanced access were innovative but insufficient. And we were convinced by the NASM report, as I hope you are, that what's needed to transform care isn't another series of learning sessions for clinicians, but rather a fundamental shift in resources and attention. So what did we do? Next slide, please. First, we invested in the primary care workforce. Like many states, California is experiencing a primary care workforce crisis. 8 million of our residents live in a primary care shortage area, and we see major disconnects between the demographics of our population and that of our health workforce. In 2017, philanthropies from across the state charged our leaders from health, education, labor, and consumer organizations to develop a strategic plan for building the health workforce of the future. Primary care was identified as one of 3 critical areas for action. And the Commission's final report, which was called Meeting the Demand for Health, captured the attention of our state leaders. 3 years later, we've seen significant action on primary care. Governor Newsom provided nearly $1 billion in funding for health workforce programs, most tied specifically to primary care and behavioral health. Our state lawmakers expanded scope of practice for nurse practitioners, and our universities made major commitments to expand their education and training programs in alignment with state needs. Overall, it was a huge success, and yet we recognize that our primary care workforce crisis is the result of generations of underinvestment. And so we knew that one-time budget allocations, no matter how big, would not be enough to correct this disadvantage. So we looked to other states, next slide, please, and countries, in fact, to learn how we might bring in more resources to primary care and to use payment to center primary care in our healthcare delivery system. Follow the money, as Chris Kohler noted yesterday. We commissioned a national scan of primary care investment activities from Friedman Healthcare. Chris previewed some of that yesterday, and I'll put a link to the final report in the chat box at the end of my session. A key takeaway from their analysis is that both states and private purchasers have multiple tools at their disposal to drive investment. Transparency, contracting, and regulatory mechanisms all work. We're lucky in California to have a long history of multi-stakeholder engagement on healthcare financing and transformation issues. Our challenge was how to capture that attention on primary care. And so to do this, we established what we call the Primary Care Investment Coordinating Group. And that brings together our largest public and private purchasers, our Medicaid programs, our public employees group, our large employers, and so forth. This group has confirmed a set of recommended actions for increasing resources for primary care in California, and I include that list in the appendix to my deck. On this slide, I give a couple of examples of the individual actions these purchasers have taken, again, to center primary care in their delivery system. In addition to those purchaser actions, we've also seen leading health plans embrace value-based payments. And in the case of Blue Shield, value-based payment with primary care at the heart. Following the footsteps of Oregon, Colorado, and some of the New England states, California has introduced legislation to measure, report, and ultimately increase primary care spending through a statewide Office of Healthcare Affordability. We expect a vote on that, fingers crossed, this June. Next slide, please. So given this activity, we were thrilled to see the NASM report. It offers a blueprint for revitalizing primary care in America. Our experience shows that having state-specific evidence on the value of primary care is also important for engaging the broad base of stakeholders that's really required to change the status quo. We've tried throughout our work to link the value of primary care to the very particular needs, values, and goals our state faces. Things like access barriers, language concordance needs, concerns about practice closures. We commissioned studies on the relationship between primary care spending as a quality, utilization, experience, and cost in both our commercial market and in our Medicaid program. These reports will be released next month, mid-April. But spoiler alert, with just a few exceptions, we saw very strong correlations between higher spending and better performance and outcome. We also highlighted consumer poll results that clearly demonstrate the value of having a primary care provider in a patient's eyes. So for example, Californians with a PCP are 30% less likely than those without to report negative experience with healthcare providers of all types. Things like being talked down to, feeling disrespected, having to repeat a test or information. Californians with the PCP are also significantly more likely to engage in healthy behaviors, to prioritize preventive care, and to follow up on recommended care. Again, releasing all this information on our website in a new collection called Primary Care Matters in mid-April. Next slides. And last but not least, we've emphasized accountability. We regularly monitor and report primary care access in Medi-Cal, and we highlight disparities with national and state guidelines and also with common sense. The secret sauce of all our efforts has been multi-stakeholder engagement and being very intentional about bringing in partners and allies, including consumer organizations, to champion for primary care. So last slide. So we're working hard and fast in the Golden State to shore up our critical primary care infrastructure, but we can't do it alone. We need federal partnership, federal guidance, and federal resources. I offer on this slide several ideas for ways that federal policy changes could enable our efforts, and I think the efforts of other states as well. We don't have time to run through all of these, so I'll highlight just a few examples. First is to remove barriers that stand in the way of state action. Reforming graduate medical education financing is a perfect example. We heard a lot about that yesterday. Second is to be a driver, not a bystander, for primary care investment. Set a target for Medicare and use the tools and influence that you have to encourage Medicaid programs across the country to follow suit. And third is to provide resources for the work. Primary care practice improvement is still a critical need, particularly in rural areas and among small and independent primary care practices. And federal resources for practice improvement have all but dried up. Our state has pledged $400 million in practice improvement grants. It's nowhere what we need to implement high quality primary care for all. Fourth, be a better partner, provide more flexibility in CMMI models, for example. And last, but again, not least, help establish or enforce some national definitions that are really critical for evaluating primary care and the health of our primary care infrastructure. So I will end there and welcome a discussion later to come today. Thank you.
Thank you, Catherine, and congratulations on the great progress and vision that you have for the state of California. Catherine will be joining us, Ms. Phillips will be joining us for panel 4, question and answer. So that will be launching following this panel, which will be moderated by Dr. Asaf Batan. Dr. Batan?
Thank you so much. And I wanted to welcome you all to our next panel, building off the last, which is looking at activities that are advancing health outcomes, access, and equity through primary healthcare strengthening in states, territories, and tribal nations. My name is Asaf Bitan. I'm Executive Director of Ariadne Labs, a health systems innovation center at the Harvard Chan School of Public Health, where I'm also an associate professor. I'm a practicing primary care physician and was an author of this NASM report. And as well, I serve as a senior advisor to CMMI on primary care policy. We are really privileged to learn from and discuss innovations that the federal government could consider to strengthen primary health care from successful experiences in regions, in states, and territories, and tribal nations in a wide variety of practice settings. We have 4 wonderful panelists to really catalyze and a discussion that I hope will be only the first of many discussions. And they are Neelam Gupta, who is the Director of Clinical Supports, Integration and Workforce Unit at the Oregon Health Authority, where she oversees the primary care home recognition program that promotes equitable patient-centered care. The Oregon legislature established this program in 2009 to identify, measure, and promote its adoption across the state through both coordinated care organizations and other mechanisms. And notably, the coordinated care organizations are required to include these recognized primary care homes in their networks as much as possible. Next will be Christina Severin, who is the president and CEO of the Community Care Cooperative, or C3, a nonprofit Massachusetts-based accountable care organization consisting of 18 federally qualified health centers. C3 is the only ACO in the state of Massachusetts that's founded and governed solely by its FQHCs and exclusively focused on advancing integrated and coordinated community-based care for its over 160,000 Medicaid members. Next is Crystal Eubanks, who is the Senior Director of Care Redesign at the Purchaser Business Group on Health and leads the California Quality Collaborative, a multi-stakeholder healthcare improvement program that's dedicated to advancing the quality and efficiency of California's healthcare delivery system across all payers through both alignment and technical assistance. At the collaborative, she also leads their technical body of work for behavioral health integration and provider organization improvement initiatives. And finally, we have Doug Eby, who is the Vice President of Medical Services for South Central Foundation, which is an Alaska Native-owned nonprofit healthcare organization serving nearly 65,000 Alaska Native and American Indian people living in the Anchorage and surrounding borough and service areas in 55 rural villages. Incorporated in 1982, it employs nearly 3,000 people in a person-centered, incredibly different and impactful healthcare system that's based on personal relationships, customer ownership, and that is creating significant improvement at lower cost. So as I said before, we have a vanishingly short time to cover a huge and critically important amount of information. So we will point to the policy relevant highlights and delve into them a bit with questions after each speaker speaks for about 7 minutes. So first up is Neelam Gupta. I will hand it over to you.
Hi, good morning. Thank you so much for having me. I'm here today to speak about Oregon's patient-centered primary care home program. Next slide, please. So Oregon's patient-centered primary care home program, or PCPCH program, was established in 2009 by the Oregon legislature as a uniquely Oregon program to support the triple aim as Oregon's early health reform efforts. The Oregon Health Authority develops the PCPCH standards in partnership with a multi-sectoral standards advisory committee that convenes every few years. Primary care practices apply to become a PCPCH by attesting to meeting the standards of how they provide care to their patients. And below you see a timeline that shows the progression of the program. Next slide, please. 3 out of 4 Oregonians receive care at a PCPCH site, regardless of coverage status, with close to 650 recognized PCPCH clinics. Any type of healthcare practice that provides comprehensive primary care is eligible to apply for PCPCH recognition. This ranges from family practice, internal medicine, naturopathic clinics, school-based health centers, tribal health clinics, behavioral health clinics with integrated primary care, FQHCs, rural health clinics, and more. Practices must be operational for at least 12 months before applying for recognition. And practices must see patients who live in Oregon, but may be based in bordering communities in Washington, Idaho, and California. Next slide, please. Now I'm going to talk a little bit about the PCPCH recognition criteria. Participation in the program is voluntary and recognition is attestation-based. So the program conducts site visits to a select number of PCPCHs each year. The PCPCH recognition criteria is defined by 6 core attributes, as you see in this house diagram, each with specific standards under each attribute and measures that indicate the extent to which a clinic is meeting that standard. There are 11 must-pass measures that all clinics must meet, and more than 50 optional measures worth 5, 10, or 15 points. There are 5 tiers of recognition based on which measures a clinic is meeting. And there is a tier 5, also known as 5-star recognition, which distinguishes exemplary practices that have implemented the most advanced PCPCH measures in the PCPCH model. Next slide, please. The PCPCH program is aligned with broader primary care reform efforts across Oregon. First, the Primary Care Spending in Oregon report is an annual report to the legislature on primary care spending by health plans and coordinated care organizations, or CCOs, which are Oregon's Medicaid managed care plans. The report helps to align payers toward value-based payments and measures progress towards the primary care spending target determined by the legislature. Also, the report informs the work of the legislatively mandated multi-sectoral primary care payment reform collaborative, which includes over 40 organizations convening since 2016 to increase investment in primary care, align reimbursement by purchasers of care, and move towards value-based payments. Lastly, our coordinated care organizations are required to provide per member per month payments to PCPCH clinics in their network as a supplement to any other payments made to PCPCHs based on tier level. Next slide, please. In 2016, researchers at Portland State University published an evaluation of the impact of the PCPCH program in Oregon. The findings were that the implementation of the program resulted in tremendous savings to Oregon's healthcare system of $240 million over a 2-year period. For every $1 increase in primary care for the PCPCH program, there's a $13 savings in other services. And the longer a clinic is a PCPCH, the lower their total cost of care over time. The cumulative effect of the PCPCH attributes has more impact on the cost and utilization than any independent effect of a single attribute. Next slide, please. The PCPCH program as a quality improvement care delivery model also has a focus on addressing health inequities. Changes to the most recent version of the recognition criteria include adding new standards on alternative visit types, health-related social needs, integrated care, such as a new oral health care measure, a measure on staff vitality, and more. We also highlight community health workers and other traditional health workers as essential care team members, and feature diverse patients when describing best practice examples. For example, preventive screenings for transgender individuals. Next slide, please. Lastly, despite these successes, not all communities have been able to access care when they need it. COVID-19 shone a bright spotlight on these issues. And as a result, we are planning to convene a standards advisory committee later this year that will include providers and community representatives, so that changes are in line with the OHA's 10-year goal of eliminating health inequities, focusing on issues that were identified through a robust community engagement process, such as lack of culturally responsive care, barriers to health literacy, an under-equipped workforce, systemic inequities and racism, distrust of the healthcare system, and the high costs of care. And thank you so much for having me. I look forward to the conversation.
Thanks so much. I'll turn it over to Christina Severin. Hi, good
Thanks.
to see you.
Good to see you too. Good morning, everybody. Glad to be with you here today, and it's going to wait until the slides appear. As noted, I'm Christina Severin, President and CEO of C3. It's going to talk about the company today, key aspects, and then double click on one program specifically. Next slide. Next slide. Overview. So we were a blank piece of paper startup in early 2016. We are a 501c3. All of the corporate members of the 501c3 are federally qualified health centers. As you can see from this slide, we have grown through the years, landing us here concurrently in 2020 with 18 FQs, over 170,000 members, not including recent diversification into a commercial risk product and a Medicare CMMI risk product, and the launching now of shared services in this FQ community, including having licensed down the Epic products and working on that implementation, welcoming in several new FQs, and we have also started a pharmacy enterprise. Next slide. This is our vision, mission, strategy, and core values. So wanted to speak to the strategy. So it is a trifecta strategy. What we're aiming to achieve at C3 is practice transformation and therefore the advancement of primary care. In doing so, to improve the historically underfinanced position of FQHCs, and lastly, advancing racial justice in our organization, in health centers, and in society at large. Next slide. This slide, just a reminder that FQHCs provide better care for patients than any other type of primary care setting when examined from a national perspective. This slide is showing you those facts on managing population with hypertension and managing a population with diabetes. And at the bottom of the slide, a couple of key facts nationally on how health center consumers are more satisfied than national non-health center consumers. Next slide. Hard to read slide, that's okay. Punchline is up top. This is data published in the American Journal of Public Health in November of 2016. Studied two cohorts over time, one who got their care in FQHCs, the other who got their care in any other type of primary care setting, and prospectively examined total cost of care and found that health centers provide total cost of care that is 24% lower than other types of primary care settings with equal or better quality. Next slide. Similar to the last presenter, we also have a model for integrated primary care. We have 7 pieces of the puzzle in this one. Similar to the last presenter from Oregon, we have a standard steward for each domain. Each domain also has a corresponding standard, and then also a specific outcome. There are also 3 tiers so that health centers can all start in one place, but then progress over time. Which leads to the next slide, is where we're going here. So part of what we are really focused on is getting off of the fee-for-service chassis and moving to primary care capitation. This slide is showing where we are projecting to be on the % of health center visits that are tied to a patient with a capitated contract by the upcoming January 2023. The blue bar represents where we think they will be on cap, and orange is remaining fee for service. Line going through it is the 70%, which is our goal. Next slide. Next slide. So people ask us a lot, and we don't have time today, how we get health centers to take two-sided risk, shared savings and shared losses. We have. The model intends to achieve these 3 goals that you see here so that we can have health centers take risk in a way that is meaningful and also responsible. Next slide. And so we let them choose from a little to medium to a lot, and we try to create a responsible match with the health center on which risk tier they would like to take and what their experience is managing to a risk-based budget and population health expertise and the strength of their balance sheet. Next slide. The model that we have with Massachusetts Medicaid for total cost of care management is a budgeted reconciliation where a benchmark is set. There is fee-for-service claims experience during the year. That experience on fee-for-service is then reconciled against the benchmark and adjusted for quality, ultimately leaving us with gains or losses. Next slide. And then lastly, wanted to leave you with just a little bit of information about a very remarkable program within this Medicaid ACO in Massachusetts called the Flexible Services Program. It supports individuals with physical health or behavioral health complexity and a need for food, nutrition, and or housing, which started in 2020. If we go, so the things that can be provided are on the right-hand side. It can be a housing search, cash assistance with transitional support, like security deposit, home delivered meals, grocery store gift cards. It can be pots and pans, medically tailored meals, etc. And if we go to the next slide, that you can see how many members. We can't update these slides quickly enough. I did these a couple of weeks ago. These numbers would be bigger now. On the left-hand side, you can see how many members have been served and who have the numbers that have been served by nutrition and housing. And then on the right-hand side, you can see the cash that has been put to work on fulfilling these needs and how that is split by nutrition and housing, the quantity spent on food vouchers, home delivered meals, and household items. And then in that bottom blue box, how other programs like RAFT have been leveraged to support the needs. And then in the closing slide, there is some real evidence here to support that these investments in alleviating certain social drivers of health are having real important outcomes for individuals and families around stabilizing perception of food security over time, actually housing people and keeping people housed, tenancy preservation services. We have also seen material decreases in total cost of care and material reductions in utilization, particularly around emergency department, and inpatient admit and readmits. Thank you very much.
Thank you so much for that description of incredible work. Next, we have Crystal Eubanks.
Thank you. So I'm here to share about the examples, building on what Catherine Phillips showed earlier of the multi-stakeholder work in California around advanced primary care. And I'll start with advanced primary care there's not a clear definition. And I just did a Google search yesterday, right? And the top 4 results net you 4 different things, but they're variations on a theme, and that's high performing primary care. And so in California, we actually have a definition and a shared definition across all different kinds of stakeholders. And I just want to share that journey that we've gone through to get there, because I think the lessons in there is that it's not unique to California. These can be applied to other states, as well as could be applied at a federal or national level to support strengthening of primary care towards high performing expectations. So our story actually starts in 2016, and in California, we received a bolus of funding from CMS's Transforming Clinical Practice Initiative that supported at least 3 networks within California to do deep practice transformation work, the elbow support, the resources to ambulatory care practices to make the changes inside the clinics and the practices. This was sustained funding over 4 years. And as we worked through this, we came together and saw that we were touching 10,000 clinicians who were impacting the lives of 6 million Californians, like 15% of the state. So we were able to do this at scale and track changes in the practices to the changes in their performance on key outcome measures over the life of this project. And we came together at the end and said, we were able to realize a 10-to-1 ROI on the investment from the government, and aggregated, we netted cost savings of more than $200 million touching it. So this is incredible. We are optimistic about building on this work. And what we have learned is that those practices that are driving those results is a narrow set of really high performing practices. And what we learned about them is a few characteristics. Of no surprise is one, they're high performing because they're paid in a certain way. They're paid more flexibly, potentially more, but they are able to use those fundings to support services beyond the standard medical care, right? That includes integrated behavioral health. The other thing we learned about them is we don't have to measure everything that they're doing, that to see high performance on managing someone's diabetes or hypertension, or seeing high performance on immunizations, right? The preventive care, that actually they netted performance across those measures when they had core systems in place. So we didn't have to ask for checklists of, are you doing X, Y, Z, send this in, add to the burden. We would see it manifested in these outcomes. So we came together and said, so how do we scale this? How do we scale this across California? And looking at each other and realized we don't scale it alone. We don't scale it by system and provider organization or one health plan or one purchaser. Because I think about one of the practices that I directly worked in, and I paint this picture. This is a practice in a storefront on a strip mall in Orange, California. So not too far from Disneyland, but definitely not the OC you see on TV, right? And this is next to the laundromat, next to the cash checking place, right? All Spanish signs, and a father and son clinicians working in a practice and serving patients and trying to make it work for them. They saw commercial patients, they saw Medicaid patients, they saw Medicare patients. And so we can no longer solve this one system at a time. We share a delivery system, right? And for each of those sets of patients they're seeing, right, they have contracts with an independent physician association, which may have a contract with multiple health plans. And they have no direction in terms of expectations or focus areas. So how do we solve for these practices? And I think to Dr. Hector Flores, and he calls it the hidden safety net. And while there are high performing federally qualified health centers who do a great job, there's a whole set of providers that serve both commercial patients as well as our Medicaid patients that aren't getting the resources and the support to be as high performing as community health centers. And in California, those make up 70% of the patients that are Medicaid beneficiaries, right? And so we're leaving them at a loss. And it's impacting not just Medicaid performance, but performance across the board. So we came together under the California Quality Collaborative, which is a multi-stakeholder group where we have purchasers, public and private, sitting next to health plan leaders, sitting next to provider organizations and patient advocacy groups, and other partners in supporting delivery system change. And so we came together and said, to start this process of scaling, we need a vision. We need shared standards. And this is something that can be applied beyond California, but we came up with a list of attributes from a patient perspective of what you would see in a practice, or call them up when you're searching for a PCP, to say, do you have X, Y, and Z, right? And because we know those attributes are directly correlated to high performance on key outcomes. And then we said, we need a measure set that we can all agree on. No more of this variation or pages of 50 measures going out to provider practices. We've got to reduce the burden and get really clear and focused on where do we expect that if you were to make the transformation changes in primary care, that you would see it manifest in that performance. So we kept ourselves to a parsimonious list, 10 measures. Can we all agree across the state? And we did, which was, to underscore, that was about a 1.5 year process of getting to a key list that was clinical measures, patient-reported outcomes, as well as value measures, right? That were important to purchasers around cost and what primary care could do around that. And so we came up with that list. It's based on existing measures, existing reporting within the state, so it's not adding additional burden. And we looked at alignment within California across the different sectors, as well as alignment with CMS. And so we have a list that we can all agree on. And now we've taken this to the next level, which is that purchasers are using this measures and attributes to start to build into their contracts. So we can start and reduce variation at the very top, right? And start to cascade through the system. So we see Covered California, the exchange in California, CalPERS, the state employee and pension and retirement system, adopting both these attributes and these measure sets. And right now collecting data on performance, but moving towards paying for outcomes on that set. Right now we're doing a pilot with the data set, knowing it's our first iteration of it and it's not ideal. And right now we're doing a pilot across 3 million commercial lives and tracking performance by practice. We've come up with shared standards around how do you identify a practice, right? And from a patient perspective of that location on the street, right? And how do we actually attribute patients to those practices? And all of this sets the stage to enable payment change, and both payment in terms of structure, but also the amount. And so our next step is we've been convening payers to come together on a voluntary basis to what can they agree on, and in places where they don't have to need to compete, right? But we can reduce some unwarranted variation. So they're coming together with voluntary commitments around transparency and reporting % of spend. And they're also coming together about, let's have a standard hybrid payment model that incorporates the NASM recommendations, right? That there's capitation, there's some fee for service, as well as performance incentives based on their payment. And then let's increase that investment in primary care, right? Look at what we could do before, like, let's realize the full potential of primary care, and then collective support for transformation. So I think in closing, like, this is applicable to other regions, and we're looking at expanding this work through the Purchaser Business Group One Health, where there's, kind of high concentrations of interested purchasers and payers. But I think the federal government can really step forward in how do we sustain the resources for practice support, and to realize the ROI on that, we really need to come up with shared standards, narrow measure sets, right? CMS can adopt a measure set. We don't need to have different measure sets across FQs and other parts of the delivery system. And then we can really work towards transparency, and particularly on the Medicaid side, and bringing in more alignment between Medicaid and commercial efforts. And so they're not working in silos, because on the ground, practices are dealing with both. So thank you for your time.
Thank you so much. You clearly highlight the value of parsimony, which is so desperately needed in primary care and all of healthcare. How do we measure the few focused, actually important things that have the most alignment across the most people? So really appreciate that. Last, we have Doug Eby. Doug.
Morning from Alaska. I'm excited by what I'm hearing these 2 days. I think that the emphasis on primary care and what's happening in private care is simply amazing. Wasn't sure what happened in my professional lifetime. However, Given the fact that this webinar is including federal and state policy and payment, and it's a very big scale conversation, I think what I've heard the last 2 days is still way too limited in scope and scale and imagination. It's time to rethink the entire healthcare system, to recenter it around people, and to pull resources to them. Next slide. It says 65,000. We actually support over 200,000 people and do a whole array of things from water and sanitation all the way up through NICU, PICU, ICU, all that kind of stuff. And do it in partnership with another tribal organization. We directly operate over 15 FQHC community health centers, support another 40. So very active in that space and other spaces. But the point here is that what we do think, we spent 25 years rethinking and redesigning an entire health system that is consumer driven. So those of us who work here are just interpreters for what the community actually wants and needs. And the takeover and ownership by the consumers is not just in the corporate office, it's actually in the philosophy of modern medicine and the structure of medical services. As you can see from all this data on the slide, we have achieved massive progress on the triple aim or quadruple aim, either way you want to go, massively improved clinical outcomes, dramatically reduced total costs, and way happier people, both giving and receiving services. Next. We do think we run the world's most powerful primary care system. I've never seen anywhere that comes close to what we're doing at scale of what primary care actually is and ought to be. At the core is a philosophy where we replace medical culture, medical understandings, and deficit-based thinking with personal relationship, shared responsibility, customer ownership, connecting and story, and the application of complex adaptive system theory. Next. We know from all across the world that what really works is companionship, partnership, trusted people who get to be known on a first name basis, where trust can develop, people can be seen and heard and actually own and drive their own healthcare journey. There are different ways to do this. You can make up for the deficits of the system through navigators, health coaches, community health workers, or you can do what we do and what this conversation is about, which is super powerful, super capable, what often people call primary care. Next. The reality is that healthcare is about 1/3 manufacturing style stuff. So NICU, PICU, operating rooms, trauma, but really the majority of healthcare these days is a service industry and a service model. And therefore the whole way we think about what's quality and how we improve and how we structure needs to be completely different. Next, we know that the real answer is to create companionship and partnership and then draw expertise and resources to that hub. So this is a very simple depiction of the actual structure of our primary care system. So in the middle are the customer owner and their family, what some people call patients. And then they have intimate relationship with basically 3 people, their primary care provider, their case manager, and their behaviorist. And for 22 years, we have guaranteed same-day access by any communication device you want to use to all of those people, guaranteed 22 years. And then immediately co-located with them is a whole array of people. So in most intimate relationship, there are behaviorists, midwives, dietitian, pharmacist, and social worker. But then co-located are a whole array of specialists that we've relocated and pulled physically into primary care. Next slide. And this list includes HIV expertise, diabetes, chronic pain, psychologists and chronic pain physical therapy, adult complexity, child complexity specialists, palliative care, aging well, psychiatrists, addiction capable people, and then a whole array of people that go into homes, home visiting, community health workers and such. And then we've also pulled pregnancy midwives and lactation into primary care as well. And then very capable social work capability. Next, a bunch of things we're working on right now is this complete integration of all ages and all people. By a year from now, we will no longer have pediatric clinics in terms of any primary care. Parents will have both generalist and pediatrician members of their team. We're doing a lot around what's called new generations. We're tripling the amount of time spent in prenatal and early childhood through parent partners, merging all the conversations before, during, and after birth. We're doing a ton of work around aging well and supporting people as they age from age 40 onwards. We've got a massive implementation of wearable devices, tens of thousands of wearable devices, connecting to an app that we've created that's in the hands of the primary care people. As I said, a ton of home visiting and ton of work continuing around chronic pain, addictions, palliative care, suicide, and generational violence and all of that kind of stuff. And by the way, you'll notice all of this list here does not require office visits or a physician-centric approach. In fact, the goal is to weave services into people's lives as they live, to pull expertise to them, and use all the communication devices that people use to communicate with human beings. And the idea that we need office visits or even virtual office visits in order to do that is completely false. We're at somewhere between 20 to 30% of our interactions on any day in primary care being in person, and all the rest is synchronous and asynchronous virtual. And that was before COVID. So we got to rethink this, people. Next slide. This is how people sit. They sit in integrated care team environments with a ton of different people in the same physical space. And then this is private space, so it's HIPAA protected. And all these people interact with each other. It's like a ballet. A primary care panel or team is about 1,000 to 1,100 people. They interact with 70 to 100 people per day, but only 10, 11, 12 in person. The rest is all done by all these different team members, weaving themselves into people's lives when, where, and how they need it. Next. And then we build a whole lot of community-based programs as well that are all spread out through the community. They get to targeted specific subpopulations, so around addictions and detox and generational violence. We do, at any given time, we run 75 to 100 learning circles a week, which is where the expert patient and the lived experience gets a ton of involvement by people interested in those topics that voluntarily show up and participate in all of these learning circles. We have tribal doctors, we have elder day programs, youth programs, we have specialized neurodevelopmental clinics for very challenged children, and all of that because the entire system is built around them, where they are, intimate, trusting relationship to a small number of people. And the real issue here, it really ticks me off to hear people talk about primary care spending. That's not the issue. The issue is primary care cost development. Total cost driven. Because from primary care, if you got weak primary care, you order a ton of labs and x-rays and pharmaceuticals and refer to a ton of specialists to make up for the fact you have no time and you're not in relationship and you don't know people. If you have human intensive primary care, you order way less lab, x-ray, pharmaceuticals, and way less referrals to specialists and drive down dramatically ER and hospital use that's preventable by super powerful primary care. So again, very few minutes to say this. If people are interested, we do tons of speaking, consulting, and challenging people in their paradigms. But the scope of what we're talking about, people, has to be expanded to be the whole system. We got to move around a lot of these specialists. We got to pull resources to where people are. We got to put these services into people's lives on their terms and quit doing this office-centric, visit-centric, professional-centric, institution-centric crap we've been doing for decades. And this has got to be reinvented around the person, the family, and trusted people and companionship, and then pulling all of these other resources towards a person. And you actually do accomplish the quadruple aim, drive down costs, dramatically improve things. And we've proven it over 25 years in a very challenged population with every social risk you can possibly come up with. And my final comment about what can the government do is, from a tribal perspective, the fact that the United States of America funds the Indian Health Service at 40% of what it spends on Medicaid and Medicare is racist, it's offensive, it's an abdication of our national responsibility to Indigenous people in this country, and it has got to stop. We got to triple, quadruple the Indian Health Service budget if we're ever going to make progress on tribal health and Indigenous health in this, our country, United States of America. And the fact that we massively underfund is just completely offensive. And the government can fix this. It's not a huge amount of money in the grand scheme of things, because the Alaska Native American Indian population is actually relatively small. So we do this at less per capita spend than the average. By risk adjustment, we should have double or triple the amount of money other people have. We do it on about 2/3 of the per capita spend with incredible outcomes, because the owners, the people, the consumers of the system drive the design and the service delivery and all of that. So there you go. Anybody curious, get a hold of us. We can talk much longer.
Thanks so much, Doug. A lot to unpack there. Really appreciate the comments. You know, we don't have a ton of time, but just to really reiterate some key points. We heard from Neelam Gupta about a successful state recognition program in Oregon that promotes advanced primary care, linked to statewide policy initiatives that's improved outcomes. Then we learned from Christina Severin about the power of FQHCs to improve care at lower cost at scale, which is what we found in the NASM report, and how payment change through contracting together with the locus and a focus at the FQHC, not hospital or medical group level, can meaningfully change incentives and take more risk in order to substantially change and improve the trajectory of care, and also to build flexible services, housing, food, nutrition, others that really primary healthcare systems should and need to be able to offer. Crystal Eubanks talked about the journey toward building shared definitions across really heterogeneous landscapes, that need for a common mental model in the service of strengthening and scaling efforts, and the need for stakeholders to work together on common measures, attributes, and reporting to address these challenges. And then we heard from Doug Eby about how to reimagine completely the provision of primary care and health services in a radically different way toward community and consumer-owned health systems based on a powerful PHC approach that is centered on accompaniment, service, and integration in the service of trust and better healing relationships, and the need to change completely our paradigm of primary care spending toward increasing amounts and redistributing funding across the system. These are major wins in the face of significant headwinds. It's clear we need more of this across the country. So could you share your thoughts on how a central coordinating council or office of primary care or structure within and across federal agencies or federal touch points that really promote primary care and pay for primary care across the country could help your innovation models be more successful, more sustainable, and ideally more disseminatable across the country even more widely? I open that up to all of you.
All right,
well,
well,
someone else comes in, I'll jump in. Go ahead, Christina.
Okay. I don't have a perfect answer. I would say that there are certainly some things that would greatly benefit from standardized approach and national leadership. For example, as many of you may have read, the CMMI CMS direct contracting program is being sort of reinvented as the ACO REACH program. Within that program, CMMI has really taken fresh new steps to recognize that there are differences in populations served for and populations that have been particularly impacted by social drivers of health, and that the origins of these social drivers of health rest in our legacy of white supremacy and economic deprivation in this country. And the REACH model is taking steps to financially adjust provider organizations' budget to reflect these characteristics. I think that's an example of federal leadership that needs to be cascaded throughout the public and private sectors. And if there were a national convener or regulator to do something like that, I think that would be of great value to primary care.
Well, this is Doug. I'm just going to pile on Christina's comment about white supremacy and so forth, and say that when it comes to privilege, the doctor-centric, institution-centric way that modern medicine is oriented from how we describe what's disease and what's not disease, and how we describe people as compliant and non-compliant, which is completely offensive, and or any of the substitute words continue to be completely offensive. And the fact that people have to come to us on our schedule at our convenience for our efficiency purposes in our institutions in something called an office visit is all privilege and abuse and power abuse and so forth. Healthcare money is a public asset, in my opinion, all healthcare money. And it needs to be redesigned around the convenience and efficacy of the people for whom that money exists, which are the people on the receiving side. And modern medicine's the most negative, blaming, guilt, shame, and harassment, professional-centric thing that people have ever done to other humans on this planet. It's abusive, it's offensive, it's doing harm, and it's not okay. And the answer is what's been discussed these last 2 days, which is partnering, companionship, trust, being seen, being heard, and reorienting all of our money and services around them, and then pulling towards them all of the resources of healthcare. And we need to quit being limited by these thing called primary care budgets and primary care costs. That is an artificial thing. Primary care drives massive amounts of money by referrals and ED and hospital and lab, pharmacy, x-ray. And we need to pull that money into this conversation and claim it as available resources to be redesigned, re-engineered, and respent around a web of communication continually in support of people's lives as they live, using whatever resources and expertise is available and makes sense to support people on those journeys. We got to blow this sucker up way more dramatically than what's been discussed the last 2 days.
And I'll jump in to say that's also the case when it comes to specific about measurement, right? And it perpetuates those systems. So what you just described in that system, we need to invest in new ways of measuring that. How do we measure the connectedness? How do we actually hear more from patients reporting their outcomes and how they feel about their health? And so we put forward a measure set, but it's not ideal. It's today's measures. So what are the future's measures, and how do we measure that system? Because measurement is going to have to be a key component.
Absolutely, Crystal. And I hate epidemiology because it is all deficit based. How much tobacco, how much alcohol, how much suicide, how much non-compliance. It is all accusatory, blaming, negative attribution stuff.
Yeah, what's your lab value, right? It dehumanizes people.
Epidemiology does not have to be that way. It just means the description of a community. So let's describe it. Alaska Native people are just described in negative terms all the time, and it does harm. It's actually violence against Alaska Native people. And the people with those struggles are, 10, 20, 30% of the population. And there's 60, 70% who are thriving and doing well, despite all the negative attributes in their environment and their system. So what's working there? What are the resilience factors, protective factors? What are the bright spots? And how do we build on those? The fact that every Alaska Native person is an abject failure is actually the remarkable thing that ought to be understood and studied, instead of all this negative ACEs studies and negative attribution epidemiology. And I'll be quiet now.
I think all of what everyone has said here is absolutely true in terms of principles that underline things, that messages that we need to promote to the federal government and everyone else in terms of what primary care is about and what we need to do. But in a practical sense, I think one of the things that we might recommend is that the federal government provide more state-based models that allow states to weigh in with their resources to help support these principles. The great examples from Alaska, from California, from Oregon and Massachusetts, and we've heard about already, strong indications that states really have a lot of skin in this game and can add a lot, and it can be very customized to the needs of their population. Certainly the population that Doug cares for is different than the population that I care for in Maryland. And there's those nuances need to be reflected in the programs if they're going to be effective. So I think that's just one practical. It's cross-cutting in some ways, but it's also very specific in another way to say, let's put states together here, and particularly in regard to the public health aspects of primary care. This is a common good that's shared between public health and primary care in so many ways. And the interplay between those two is very synergistic.
And I'd like to add, I welcome partnerships, and not just to let the states innovate and support that, but partnership with the feds, join in the state initiatives. And
Yes.
And I've been asked how could the federal government partner? And I don't have a great answer, right? We haven't explored it. And so I think there's some investment of how do you come in and not just let things go forward, but actually come in as a key core partner. Because when I that point of solving for our providers panel, right? It has to work across the panel, right? That the federal CMS is a payer and a purchaser right there alongside everyone else. And so to solve for them differently and not be a part of those state models is really challenging for it to be successful.
I would just comment on, I touched on this robust community engagement process we had gone through. It was a 9-month process where we listened to 30 community groups to learn what the barriers were that they encountered, as well as we looked at numerous documents, recognizing that communities have been telling us the issues that they've encountered for a long time. And so based on that, our next iteration of the Standards Advisory Committee that is going to advise on how we need to revise the model is going to include community representatives. About half of the group will be outside of the traditional industry stakeholders. And then Dr. Bitton, I see you also asked a question too about how Oregon has shifted payment. One example is we've really invested in health-related social needs. For example, do patients need an air conditioner? We funded some of those essential services as well.
Fantastic. Well, we have one minute left. Any final parting comments again on the theme of what can states, regions, federal government do in the coming months, in the coming year to sort of make this vision a reality based on your experiences? And maybe we'll do a round robin, 2 or 3 literal sentences or bullet points. Next steps. Start with you, Christina.
Do not have confidence that in the absence of rules and regulation, that industry will come together to rally around the same aligned principles.
Krista?
Put forward some shared standards and common approaches to investment in primary care, those models, and the measurement, and not just to solve for the immediate future, but start thinking now about how do we do this for the future of the system we envision.
Howard?
Yes. So align the level of investment with the work that needs to be done, so that there's sufficient investment so that we don't fall short because we don't have the resources.
Doug?
Segregating the money in the conversation into buckets. There should not be a primary care conversation separate from a healthcare system conversation. It's all money. Most of the money in healthcare is driven by what happens or does not happen in primary care. Let's make it a whole conversation, make all that money available to the conversation.
And Neelam?
2 things that I haven't said before. Oregon is making tremendous investments in behavioral health care, given the huge crisis we've experienced that existed before COVID and just been exacerbated across improving the healthcare system and strengthening the workforce. And then I'll also say, just making sure that the workforce is really aligned to patients is really critical. In particular, getting workforce types like community health workers, peer support specialists, peer wellness specialists, system navigators. We have a new category of what we call traditional health workers, called tribal traditional health workers as well. So just, trying to make sure that the workforce really meets patient needs.
Thank you all so much to our 5 incredible panelists. And I'm excited to turn over to Dr. Hughes for the next panel. Thank you so much.
Good morning, everyone, and welcome to panel 4. My name is Lauren Hughes, and I'm an associate professor of family medicine at the University of Colorado School of Medicine and the state policy director of the Farley Health Policy Center. Our next panel will focus on how state-federal partnerships can improve health outcomes, access, and equity by strengthening primary health care. We have 4 very distinguished panelists to help us with the discussion today, and I will introduce them in the order in which they will speak. They are Dominic Mack. Dr. Mack is a professor of family medicine at Morehouse School of Medicine and serves as director of the National Center for Primary Care, where he leads the development of health equity and population health strategies to further research, innovations, and trainings that advance primary care systems. Next is Catherine King-Cristaldi. Dr. King-Cristaldi is associate professor and the medical director for school-based health at MUSC Health of the Medical University of South Carolina. Bill Berman. Dr. Berman is a primary care provider for persons with HIV and the former executive director of the Public Health Institute at Denver Health. Kelly Hughes. Ms. Hughes is an associate director in the health program at the National Conference of State Legislatures. She oversees staff and projects related to health access, costs, and coverage policy issues. And lastly, Ms. Catherine Phillips, the Senior Program Officer at the California Healthcare Foundation. She spoke during an earlier session today on how state levers may be used to transform primary healthcare. Catherine will be joining this team for the Q&A portion. Each speaker will have 7 minutes to present, and we will use the remaining time within the session for Q&A. And we will start first with you, Dr. Mack.
Lauren, I might suggest that we go to our next speaker and then come back to Dr. Mack.
That sounds great. Catherine, let's have you, Dr. King-Cristaldi, let's have you jump into the queue next. Thank you.
Sure, no problem. And I'm just going to share my slides here. Thank you for having me. I'm Catherine King-Cristaldi. I'm the Associate Executive Medical Director for Telehealth here at the Medical University of South Carolina and the Associate Program Director for our National Telehealth Center of Excellence. I'm going to try and quickly touch on what we do here in South Carolina and in particular telehealth for primary care, health equity, and our South Carolina Telehealth Alliance. This is just a brief timeline to sort of set the stage and understand exactly where our funding and value in telehealth is realized. We have had telehealth programs at the Medical University of South Carolina for quite a while, but in 2013, 2014, the state of South Carolina invested heavily in telehealth as a way to reduce healthcare disparities within the state. At the same time, our South Carolina Telehealth Alliance was formed. And then in 2017, we began our designation as a National Telehealth Center of Excellence with the charge to rigorously evaluate our telehealth programs to inform public policy. This is a bit of a dated slide, but just lets you know that we are charged by the state with really forming a telehealth network across the state of South Carolina. We've organized our telehealth services into the ways that they show value to our individual stakeholders. And today we'll really focus on those programs and a couple of examples of programs that support primary care and help to achieve health equity within our state. School-based telehealth is one that was really invested in by the state of South Carolina with the thought that we would really be looking at how to reduce healthcare disparities for children in particularly underserved areas of the state. And so by connecting to school nurses' offices in Title I schools, we're able to provide access to care right in the school nurse's office. In particular, we focus on asthma, ADHD, and specialty mental health services. We've shown some significant outcomes to show value to our state government. This program really was really targeted the populations that needed it the most. It really used a precision public health deployment to plan and grow this program. In the first map, you see where children use the emergency department for asthma twice as much as you would expect, highlighted in red. The next map was a map presented to us by the State Department of Education showing school districts that ranked in the bottom 5% nationally. And you can see that we have grown our program to really address these two disparities. And then we have a large effort in supporting rural and underserved primary care offices. You can see we take a multi-system approach to how we support those, really the mission of primary care through different telehealth modalities. You'll see where we've really applied telehealth technology to the behavioral health integration. And most recently, we've said with the same model, could we not layer upon weight management and other primary care centric models, centralizing either the behavioral health care manager or a registered dietitian via telehealth to serve as many primary care clinics as possible. Another centralized process that we offer to rural primary care clinics, the majority of which are FQHCs and free clinics, is diabetes remote patient monitoring, again, centralized at our location with a team of nurses who use an algorithmic approach to monitor thousands of patients with diabetes in tandem with their primary care provider locally. These next few slides just touch on how we were able to quickly adapt some of our telehealth programs and really use a public health approach to deploying pandemic-centric services. So we used our virtual urgent care program to screen patients throughout the state and then deployed rapid pop-up screening sites to test patients and then enroll positive patients in home monitoring. And these are just a couple of qualitative quotes from our patients who were involved in the home monitoring program that's really grown into now a post-discharge monitoring program to help make room in our hospitals throughout the state, and hopefully will evolve into how we best manage patients in the post-acute setting. This shows a little bit of how we've approached evaluation, and we have some funding through the AHRQ to evaluate the systemic use of these programs during the COVID-19 pandemic. Just a little bit of time spent on what is the South Carolina Telehealth Alliance. This was formed after the state invested heavily in telehealth as a way to bring together all the major healthcare systems, state agencies, and other stakeholders in the state to really form a collaborative model among those who were traditionally not particularly collaborative, and expand access to telehealth services throughout the state. It functions to both collaborate in a strategic planning process annually, and then throughout that strategic planning process, a series of contracted partnerships are formed to really carry out the work in that strategic plan, which is then reported quarterly and then eventually annually to the state legislature. And that funding has gone on now. We're getting close to 10 years of line item budget. From that collaboration, we would support these kind of 3 policy implications that were put forth here. And this article was just really helpful, I think. And so as a group, we've worked together within the state to support how we can, both at the state and federal level, think through these major barriers. Within our state in particularly, we've mapped in very rigorous detail broadband access throughout the state, and have been able to really move the needle there through that collaboration. So that is quickly what we do in the state in this topic area, and I'm happy to speak to it a little bit more.
Thank you very much, Dr. King-Cristaldi. We have Dr. Mack back with us, and I will turn it to him next.
Thank you, Laura. I'll keep my video off for the moment. We lost power, so my apologies. First slide. So this is where I left off. This is the Southeast Regional Clinician Network, and the gist of it is we've worked across the 8 states with 8 PCAs and the 203 FQHCs to develop this network as a practice-based research network and to help with the healthcare issues in the Southeast. Next slide. PBRNs are valuable. They allow clinicians and healthcare leadership to connect with mission-focused partners throughout the region. They also help the clinicians and their practices to promote balance and resilience in their professional life and work with more system-based issues versus local clinical issues. Translate the valuable lessons that they learn into practice to benefit the broader community, but also the ability to have valuable CMM opportunities and increase quality outcomes. Example of some of the works that we've done with the practice-based research are here, the scientific research. We want to highlight the diabetic self-management research, which we did with primary care clinicians, quality improvement staff, and patients who had non-insulin dependent diabetes mellitus. And this program helped to optimize health, but also reduce financial burden on patients and families. Next slide. This is Mitchell, Danita, and Ann, our director, who's a Case Western liaison for Morehouse School of Medicine. And this is our team. Next slide. The second model is structured to provide solutions and help answer the questions that we were all asking with COVID-19. What are the underserved communities suffering? Why are they suffering from disparities in prevention, vaccine exposure, sickness, and death? The National COVID-19 Resiliency Network is an OMH cooperative agreement with Morehouse School of Medicine, focusing on those populations that were disproportionately impacted with COVID-19. There's 6 objectives, but this is a model to approach communities with different, with this methodology, no matter what the social or the clinical issue may be. Identify, engage, and partner with disproportionately impacted communities, in this case, across state, territories, and tribes. Develop an active information dissemination network, disseminate culturally and linguistically appropriate information, but the cornerstone is to link target communities to COVID-19 healthcare and social services. We are to monitor and evaluate our success, but also bring awareness, use comprehensive dissemination scientific methods and strategies, including publications, white papers, etc., to get the word out there. Next slide. This initiative is partner and community centered. We have over 25 strategic partners who are contracted or have MOUs that are across those disproportionately impacted communities, but we also have 300 community partners outside of that. Partners represent diverse communities, and we host multiple national forums, including our National Community Coalition Board, which we recently had over 150 participants from diverse communities. We have breakout rooms, discuss hot topics, and share information and best practices. This initiative is made for community by community. Next practice, next slide, I'm sorry. Innovative technology development supports the work of the network. On the back end, we aggregate public and private COVID-19 and other health-related databases. This is supported by an interactive web-based interface with visualization tools. Approximately 600 signals support index measures within the tool. There's downloadable, customized data sets and resource listing that are available. And researchers have the ability to look at index measures and compare geographic areas with high concentrations of at-risk communities to other regions of the US. Next slide. On the front end, multicultural, multilingual community approach. Communities can access information and services in their language through a website and mobile app. We work with strategic partners and take a social marketing approach to message development, conducting surveys and focus group and with community partners and members to develop all of the resources. Next slide. We recently had a second round of micro grants awarded to 15 community-based organizations. Through these grants, over 200,000 community members, people in the community, were engaged through in-person or virtual events. Over 130,000 reached through social media broadcasts and phone. Over 100,000 COVID-19 related materials were distributed. 10 of these 15 awardees conducted vaccination programs, and 2 of the awardees were involved in research. It is important that funding is distributed directly to the community and community-based organizations to develop our programs. Next slide. So this is the slide before the last slide. But what I like to say is successful models for approaching communities must be built on an understanding and respect for diverse cultures and communities. They must, number one, prioritize their needs. Number two, engage at the grassroots level. Number three, target health disparities. Number four, act on the data. And number five, continuously learn and improve. It's a learning health system approach, and we call it PEDAL at the National Center for Primary Care. Next slide. Just want to show you our team. It goes across multiple units at Morehouse School of Medicine. Dr. Rice, our illustrious president, but I also want to point out our Director of Research and Policy, Dr. Megan Douglas, who's also doing some work with the National Academy. Thank you for having us today and look forward to the conversation.
Thank you very much, Dr. Mack. And Dr. Berman, I will turn it over to you next. Dr. Berman, I believe you're on mute. It looks like you're connecting, you might be connected to audio now. Yeah, I can hear you now. Go ahead.
Great. So bring on slides. I took as my charge to talk about going from theory to practice. There's lots of talk about building effective collaborations in primary care and public health, and to provide an example at a local level of doing that. So I work at Denver Health, next slide, and have for most of my career. And I just wanted to say a few words about the structure of that organization. I won't go through everything on this slide, but just to focus on a few aspects of the system that provides safety net care for entire community through all kinds of venues. And to show that, for example, we have 10 primary care centers, family health centers, 20 school-based health centers, a wide range of behavioral health treatment centers, and correctional care, all of which let us do a whole lot of things across the system. Next slide. Just a couple of words about where I come from, because that obviously affects what I see and what I say. As was mentioned, I still am a primary care provider for people with HIV infection and have been for more than 30 years. And I just retired from being the director of the Public Health Institute at Denver Health. And much of the last 6 or 7 years have been spent on something that's shown below, the Metro Denver Partnership for Health, a collaboration between 7 counties and the Human Services Department, 6 public health departments, and 6 large healthcare systems to try to really produce change at a population level. Next slide. About 10 years ago, as I started to work with primary care systems in Denver, there was a clear need to focus. There are all kinds of topics that one might try to address. And after community consultation and a lot of discussion and use of this tool, so this is the Global Burden of Disease website from the University of Washington, showing for the United States, and it's equally true for our specific communities, that 58% of the entire burden of disease in the United States can be attributable to tobacco and a constellation of factors that are related to poor diet and lack of exercise. Next slide. So we chose to focus a lot of our work on tobacco. I won't go over nearly all the community-based interventions we did. They had a lot to do with effective communication and also working towards some policy changes. But a lot of our work was focused on this idea of, can we use a simple intervention, have it integrated into every care site in the whole system, and produce population level effects. And the intervention we chose was Ask, Advise, Intervene, tobacco cessation. And this just shows the results of a Cochrane review of the impact of primary care or specialty care, any care interactions with individuals about smoking, that you can increase quitting from 7% with just brief advice to 13% with counseling, medications, and brief advice. Next slide. So we work very closely with our primary care provider colleagues in the family health centers, school-based health centers, and we really tried to use each other's strengths. So from public health, we brought funding from the state tobacco tax, training on developing these services, policy and communication work, and data at the community level. Our primary care provider partners provided tremendous tobacco champions. We had tremendous support within their healthcare workforce for this initiative, a great QI structure that really let us improve things, and data at the clinic level. Next slide. So this really is the work of a decade. When it started back in 2011 and 2012, we had a distressingly high smoking rate in the population we care for, more than a quarter of them, fairly typical for low-income populations. And then we started to work, and we just took on one thing at a time. We didn't try to do everything at once. We started actually with just 3 clinics and then steadily expanded our work to introduce screening, advising, and provision of assistance to smokers who wish to quit. We did all kinds of relatively small but important QI initiatives along the way. And we've seen, since we started, a steady 1 percentage point per year decrease in the state in adult smoking prevalence. And I'll say that an independent review by the University of Colorado demonstrated this was not true for most low-income populations in Colorado. And they estimate that this intervention produced or reduced major cardiovascular disease events just as one health outcome at the rate of 1 stroke or heart attack per week. Currently, our adult smoking prevalence is at 16%. Next slide. And so what did we learn from that? I think we learned the importance of these 4 factors, that alignment across the entire system was critical, that focus, we didn't try everything, we tried to do one thing really well, which was enhance tobacco cessation. We involved the entire systems, clinics, specialty care, dental care, behavioral care, public health, the emergency department, hospital, everybody. And we use improvement tools to drive this all. So finally, next slide. I want to step back and say, what does this tell us about the broader topic of trying to build effective collaborations between primary care and public health? And these are my conclusions of that decade of work. The first is that personal relationships matter, that trust enables collaboration on chronic and urgent, like COVID-19 community needs. We need authentic and funded community engagement, and we did a lot of that during COVID. I'm happy to talk about that later. We need a shared and a short agenda. So we focused on really a lot of this effort on one topic. We've since expanded to a number of other ones. As a public health provider, you need to know the pressures that are faced by your partners so that you can help them meet the requirements that their funders are setting. Clear role definition and using the strengths of each part is helpful. And then finally, meaningful metrics to drive quality improvement. So I hope I've demonstrated a single example of a critical topic, which is developing more effective relationships between primary care and public health. And I'll close.
Thank you very much, Dr. Berman. And I would now like to turn it over to Kelly Hughes. It's all you.
Great. Thank you so much for having me. Okay, great. I see the slides are being shared. Awesome. So thanks so much for having me. It's an honor to be here among this distinguished panel. And as Lauren mentioned, I'm Kelly Hughes. I'm an associate director in our health program at NCSL, which is the National Conference of State Legislatures, where I oversee our work on health access, costs, and coverage. So really all things healthcare policy. NCSL, for those that aren't aware, is the nation's bipartisan organization that serves all 7,383 state legislators and more than 25,000 legislative staff across all 50 states, DC, and the territories. And we really, our goal is to strengthen the legislative institution because we know that when states are strong, our nation is strong. One of the primary services we offer to our members is to research, track, and analyze state legislation. And to do so, we maintain 50, I'm sorry, I'm hearing a little background noise. Is anyone else hearing that? Thanks so much. So we maintain nearly 50 legislative databases that are publicly available on our website, and 9 of those, I think at least 9 of those, are health related. So today I'm just going to talk about give you the 30,000 foot view of state legislative efforts that we're seeing at NCSL to strengthen primary care. Next slide. So we all know that increasing access to quality primary care really requires engagement across a variety of sectors and stakeholders, and state legislators are certainly one of those stakeholders, given their role as appropriators and regulators and consumer protectors, So some of the policy trends we're seeing in states to strengthen primary health care that I'll touch on briefly are implementing value-based payment reforms. None of this is going to be news to you all. You've heard these. Modifying telehealth and licensing policies, and then also bolstering the health workforce. Some topics that are also very important that are relevant to primary care that I won't have time to talk about are really state and that we're seeing across states is supporting struggling health facilities, assessing certificate of need regulations, increasing access to primary care services through FQHCs, and then also health insurance, both Medicaid and commercial insurance it's a key component to accessing care. It really facilitates entry into the healthcare system. And it continues to be a major focus for state legislators year after year and issues we cover closely at NCSL. So I want to highlight those. They're very important. Won't have time to get into them much. But with that, let's get into payment reforms. Next slide. So with health prices on the rise, states are increasingly considering alternative or value-based payment reforms that aim to both lower costs, but also improve quality and outcomes. And of course, we know there are many different models, some of which are pictured here. The common thread across these models is that they reward and incentivize value over volume. So ACOs, this is a value-based reimbursement model. In 2021, at least 9 state Medicaid programs have reported having ACOs in place. Early results have shown too that they decrease emergency department utilization and hospital admissions. When we talk about health costs, it's a huge umbrella. When we talk about health costs, there's costs to the state. Usually that's through the Medicaid program. There's costs to the system, and then there's costs to consumers. And you can address one of them, but they tend to kind of show up in other aspects of costs. And so we really, when we think about addressing healthcare costs, we want to think about the entire system and where those costs are being kind of realized, and really think about it kind of more holistically. Patient-centered medical homes is more of a delivery model, but certainly can help with addressing high-cost, high-need patients. Many states have been using this model to strengthen Medicaid primary care, and in 2021, at least 25 state Medicaid programs served some Medicaid beneficiaries through a patient-centered medical home. And we're also seeing some states launching multi-payer patient-centered medical homes, and Arkansas is a great example of that. There's also capitation, and which is more common in MCOs, bundled payments, less relevant, I think, in primary care. And then also direct primary care agreements, which are essentially contracts between a primary care provider and a patient, in which the provider agrees to provide primary care services to the patient for an agreed upon fee, which is usually monthly, somewhere between $50 and $200. This is we're seeing these numbers rise in recent years. As of 2020, I believe, actually it might be 2021, 32 states have laws that generally define direct primary care as a medical service arrangement outside of state insurance regulation. And then and there are a number of pending bills too that would expand direct primary cares to state employees and or to Medicaid. And then lastly, I just wanted to highlight that states are also establishing offices to examine, oversee, and direct value-based care. In 2021, Delaware required the Office of Value-Based Healthcare Delivery within the Department of Insurance or the Division of Insurance to establish mandatory minimums for payment innovations for health insurers. And this particular legislation also required insurers to spend a certain percentage on primary care. We're also seeing in 2021, Maine also established the Office of Affordable Healthcare to monitor the adoption of alternative payment models. So that's just a little bit on payment and delivery. Next slide, please. Let's pivot to telehealth. So states have taken a wide variety of actions to increase access to primary care via telehealth, which one of my fellow colleagues highlighted earlier. Some of the trends that we're seeing are lifting site restrictions, streamlining licensing requirements, and then allowing a provider-patient relationship to be established via telehealth. Next slide. So some of the areas where we've seen significant action in the last year or two is Medicaid coverage, private insurance coverage, and then also more opportunities for audio-only visits. So on the Medicaid front, we have seen states expand the types of telehealth visits that would be covered by Medicaid beyond just live video. And then a few states also enacted legislation requiring Medicaid programs to reimburse for telehealth at the same rate as in-person services, which we know as payment parity. We're also seeing that across private insurance as well. Some states like Massachusetts and Rhode Island established payment parity requirements, but only for specific services like primary care or mental health services. And then in terms of audio only, at least 29 states enacted legislation in 2021, expanding access to audio only telephone consultations, which many providers have leveraged for primary care. Next slide. Make sure I'm doing okay on time. Okay, so I wanted to just briefly highlight state strategies and trends to expand and retain the primary care workforce, particularly in shortage areas. And these are some of the areas and trends that we're seeing across states. So with licensing, we know that in order for providers to deliver services via telehealth, they have to be licensed in the state where the patient is receiving care, and then also be licensed in the state where the provider is located. And one way that states can bypass this kind of burdensome licensing process to facilitate telehealth across those state lines is to join a licensure compact. So we're seeing an increase in the number of states in the interstate medical licensure compact. Indiana was the 37th state to join the compact. And then the NLC, the nurse licensure compact, there are 39 states that have joined that compact. Scope of practice is a huge area for us at NCSL. We are seeing that states leveraging the role of nurse practitioners and physician assistants, and really examining their scope of practice to address workforce shortages and increase access to primary care. Practice requirements, their ability to practice independently or with physician oversight or somewhere in the middle, is probably the biggest issue that we're seeing with nurse practitioners and physician assistants. And I just wanted to plug, NCSL maintains a publicly available website, the Scope of Practice Policy. It's scopeofpracticepolicy.org. And on this site, we track state legislation, policy information for 21 different policy areas across 9 different provider types, including nurse practitioners, physician assistants. We also have a legislative database that we've maintained since 2015, and it includes community health workers. It's a great resource. We expand new content every year, so be sure to check that out.
And Kelly, I'll ask you to provide a concluding comment.
Okay,
Yes,
can you do next slide real quick? I'm so sorry. I feel like I could talk about this forever. These are just, I know we'll get into this a little bit later, but opportunities for HHS to support states. Funding, of course, there's, with ARPA, we're definitely seeing states spending those funds and allocating those for health-related purposes. Flexibility in how funds are spent. This was highlighted earlier, but every state has a different population that they serve and kind of unique context. And so really giving states a flexibility there. Data, I'm sure we'll get into that. And then because we are a bipartisan organization, messaging is really important. The words that we use and how we speak to policymakers matters. And so I'll leave that there. And then the next slide, is just a list of NCSL resources on this topic that you can reference later. Thanks so much.
Thank you very much, Kelly. And I'll have all the panelists join me, and please turn on your videos for our Q&A session. We'll have approximately 10 minutes for this portion. Before I jump into the question, I do want to thank all the panelists for your time and talents and expertise today. Very much appreciated on this incredibly important topic. I'm going to start with a question that I'm going to pose to all 5 individuals that spoke today, as well as Catherine Phillips, who was part of an earlier panel. And to Kelly's point, at the end, it will be about data. So the question is as follows: what data is currently available, and or what additional data is needed to support the efforts you discussed today? And I will start with Dr. King-Cristaldi.
Thank you. Yeah, that's a great question. I think reflecting upon some of Kelly's comments as well, I think there is a struggle to come up with the data to support appropriate reimbursement for telehealth at this point. And for better or for worse, we've now had a pretty complex natural experiment happen over the last 2 years that has supplied us with a little bit more data. But at this point, people really need to feel secure in their business planning going forward that this reimbursement is going to continue, and that it's going to continue in a way that is honors the value created by these programs. That's what I would say at this point.
Thank you very much. Dr. Mack, I'll go to you next. I'm going to go to each of the panelists in order that you spoke today. Dominic.
Thank you. Thank you. What I spoke about today were a lot of community engagement efforts and also implementation science, so to speak. There are a lot of available databases, public and private. We've used a lot of Medicaid claims data, but I think the challenges are these, they're siloed. The information is so siloed, the integration and interoperability. And some we found in some of the research we've done around the public health information, it's not descriptive enough around demographic information, that social determinant information that could really be helpful to these underserved communities, rural communities. So I leave with saying that interoperability, we have a lot of data out there, we need more, but it's a lot of data out there. It's not interoperable, it's not exchanged. You can't get it at the point of care when you need it, but also it's not accessible to the community. And we have to make it accessible to the community so they can help themselves.
Thank you very much for your response. Dr. Berman.
I think we need effective local data. I'm always impressed by when you produce maps, for example, and people say, is that my neighborhood? Is that the smoking rate, the death rate from COVID in my community, in my neighborhood? And so I think bringing that together with clinical data is powerful, and eventually using clinical data as the data source for a lot of that local data. Local data, even if it just reflects national trends, is powerful.
Thank you. Kelly.
Yeah, I'll speak on behalf of legislators. I mean, what matters to legislators, often what we hear at NCSL is what works. So what are other states doing that's working, and how can we prove that it's working? So they care about cost savings. They want to know about health outcomes, but I think probably cost savings might be the bigger push. And then I think human interest stories are also really moving for legislators. So some combination of that is I think what really compels a legislator to pursue, I don't want to say to necessarily pursue policy, but I mean, that certainly is a driving factor. I think workforce shortage data is like, what do HPSAs mean in really plain language? Like, how is this calculated? Because sometimes I've had a legislator look at their urban city and say, there's a shortage. We have these major health systems. How could there possibly be a workforce shortage? So I think just unpacking the complexities of that, I think, we can get into health information exchange. I mean, that's probably another conversation, but I think there are legislators may or may not understand HIPAA laws, effectively and know what is that. There's a lot of pushback on sharing data and privacy concerns. And I think unpacking that can be really helpful. Claims data is another one that we could get into. But I really think if you had to boil it down, it's like, what works? What are other states doing? And how can we prove that it's working? And then how does this affect my constituency?
Thank you. And then Catherine Phillips, I'll turn it to you. Thank you for joining our Q&A today.
Thank you for having me back. So California is working on an all-payer claims database, and that I think will provide tremendous information akin to what we saw from Maryland on cost and effectiveness and investment potential. I'll highlight two, one at the provider level and one at the patient level. As I mentioned in my presentation, we are working on health disparities, and yet most health plans in our state and most providers in our state don't have complete real information, race, ethnicity, or language information on their patients. That makes it very hard, whether it's at the zip code level, as Kelly indicated, or at the state level, to know where those disparities exist and where to target action. And second, our medical boards and our Bureau of Registered Nursing do not routinely require the submission of race, ethnicity, or language data for our providers. And that also makes it very difficult to know, do these pipeline programs that we're investing in work? Are we changing the demographics of our workforce fast enough and in the areas where it's needed most? So I'd like to see those two elements change.
Great, thank you. Appreciate your responses to that question. I have several more questions myself, but we did have a question come in for you, Dr. Berman. And this is related to your smoking cessation program. And there's sort of a bundle of 3 questions. So I wanted to give you a heads up on that. The first is, could you speak to task shifting with regard to smoking cessation? Number 2, do you also address comorbidities at the same time, such as depression or alcohol use? And third, if you could comment on the impact of the COVID-19 pandemic on this program.
Yeah, sure. That's a great question. For the first, yes. So medical assistants in our system both do the tobacco screening and provide some additional messaging about the importance of cessation. Then providers their role is to support the messaging and, if interested, to provide additional assistance, including prescription of tobacco cessation medications, which we encourage. They work. So secondly, give me the second part again.
Was addressing comorbidities at the same time.
Yes, thanks. So we focus for the initial part of this only on tobacco. I'm a primary care provider, and if someone comes to me and says, I have yet another thing to put into your 15-minute encounter, I would invite them to jump out the window. I don't have those minutes. And so we realize there are many, many other important things. We focus this solely on tobacco cessation. I think that's part of its success. I will say, having had this success, we've turned the lessons, the system level lessons, towards some of these other important topics like depression and alcohol. And then third, during COVID, what we did primarily was pivot to telephone-based services even more. We had started before then, but we really went to telephone-based tobacco cessation, and it's worked very well. Show rates for appointments are dramatically higher, and the outcomes, which we've looked at, look like they're excellent. So just another pitch for telehealth.
Wonderful. Thank you so much, Dr. Berman. And it looks like we do not have another question yet in from the audience, so I will ask another one of mine. We have about 3 minutes left for Q&A, so I'll ask for all panelists to be very crisp and clear in your responses so we can keep our webinar on time. Beyond what you discussed today in your presentations, I'd love to hear from any combination of you of additional state-federal partnerships that you are aware of that strengthen primary health care that you think will be important to bring to the attention of this audience. And I would put a plug in for any state-federal partnerships that really help advance rural and or frontier primary care. If you have any examples there that you can offer up to the mix. And whoever would like to jump in first, you're welcome to provide an example.
I'll go first since it was, oh, go ahead.
Oh, thanks. I'll start by just saying that I really focus on correctional care because I think it serves some of our most vulnerable patients, and we lock up people's medical records just like we lock them up. It's a ridiculous thing. And so I'll provide just one very specific suggestion. Medicaid should pay for correctional care in jails. There. Specific would be a dramatic advance.
Thank you, Dr. Berman. Dr. King-Cristaldi.
Sure. So I mean, in our state, because we have this sort of federation for state partnerships, certainly our own South Carolina Telehealth Alliance, which includes our state Medicaid, state legislature, and several other state agencies, Department of Mental Health, Education, et cetera. At the federal level, certainly we do a lot of work with HRSA and certainly Medicare. I think the funding of FQHCs is the infrastructure for the underserved in primary care in our country is also particularly important.
And Dr. Mack, last word here so we can keep everything on time.
Okay, quickly. Our Department of Community Health and our Medicaid department develops quality programs for providers and does some pilots around primary care. Nationally, I think the Aim Ahead program has some potential for FQHCs, but it's a lot to be developed. But those are two I can think of.
Thank you so much.
That's from NIH Aim Ahead.
Thank you, Dr. Mack, and to all of our panelists, and Catherine for joining us for the Q&A. Thank you so much. And I would now like to turn it over to my colleague, Ann Greiner, who's the Executive Director of the Primary Care Collaborative, to lead us into the next panel.
Thank you so much, Lauren. Appreciate the handoff. I'm Ann Greiner. I'm President and CEO of the Primary Care Collaborative. And I am so pleased to have this fifth panel on the second day of our workshop, which has really been tremendous. And I really want to thank NASM and Dr. Bob Phillips and Dr. Judy Steinberg for all of their effort to convene these terrific 2 days. Our panel is going to be focused on how can communities and primary care clinicians, primary care health professionals, support our movement to strengthening primary care. And we have two just terrific speakers. Let me first introduce our first speaker, Brandon Wilson, and he is just joined Community Catalyst as Director of the Center for Consumer Engagement in Health Innovation. He comes to Community Catalyst from CMS, where he was a public health advisor in the Office of Minority Health. And there he partnered with federal partners and other CMS stakeholders to advance health equity in regulations and in payment. And he also worked on strengthening the business case for health equity. His work was recognized. He recently received a CMS Impact Award from our CMS administrator, Chiquita Brooks LaShore. Prior to joining CMS, he led portfolios at CMMI within the Accountable Health Communities model and also within the Healthcare Innovation Award sector. Prior to CMMI, he was at NIH, where he worked on recruitment and retention for increasing minority screening and enrollment in vaccine trials. Dr. Wilson has a master's in health system management from George Mason and Doctor of Public Health from Morgan State University. Next up will be Sherry Erickson. She's Chief Advocacy Officer and SVP of Government Affairs and Public Policy at the American College of Physicians. She oversees ACP's Washington office and manages all advocacy and public policy initiatives. She also oversees the Department of Medical Practice. In addition, she currently serves and has served for some time, thank you very much, Sherry, as co-chair of the Primary Care Collaborative's Public Policy and Advocacy Work Group. Before coming to ACP, she was a senior program director at NQF. She received her master's of public health from Johns Hopkins and also has a Bachelor of Arts from Miami University. So we have a half an hour for our panel. Each of our speakers is going to take 8 minutes, and then we're going to have quite a lot of time for questions from the audience. So be thinking about your questions as you hear first Brandon and then Sherry offer some remarks. Over to you, Brandon.
Sure. Thank you, Ann. It's good to be here. First thing I want to speak on as far as bringing the community perspective in is the concept of person-centered care. At Community Catalyst, the Center for Consumer Engagement and Health Innovation, we actually recently completed an analysis of the state of person-centered care, and we provided a first ever look at how person-centered care models are working or not on behalf of older adults. And what we found is that there's really a lot of improvement needed for our underserved communities. And we compared data from 2014, 16, and 18 from the Health and Retirement Study. And our researchers looked at whether the older adults' preferences are taken into account by physicians and other care providers, and whether or not that's heavily dependent upon things such as race, insurance, and income level. And specifically, they found that 1/3 of people 50 and older rarely or never have their care preferences taken into account by clinicians. And with more people of color and lower income individuals saying so. Black and Hispanic older adults are also more likely to report never having their health preferences considered. Individuals who report their clinicians never account for their preferences are also twice as more likely to be low income. And a higher number of persons on Medicaid report clinicians sometimes or never consider their preferences. Relatedly, we also commissioned a few focus groups to understand consumers experience in their attitudes with primary care. And we looked specifically at some of the intersections with social determinants. And we found, we focus on marginalized groups, including those with low income, those with disabilities, and from communities of color. And we were intentional in identifying populations that generally do not feel well served by the healthcare system that we encounter today. And these persons are really dealing with a variety of significant challenges that in their estimation have a pretty significant and direct impact on their health, while also impacting their ability to access the needed services and resources. These challenges are often defined by severe financial stress, including lack of reliable transportation, food insecurity, access to healthy food, housing security, and the ability to address their mental health and emotional challenges. They often felt that the healthcare system is financially driven, and it leads to short and impersonal primary care visits. They're really cynical about the system that they felt is designed, excuse me, to really churn them through as quickly as possible just to get to the next patient. The next point is we actually then asked them a follow-up question of how would they describe and imagine our aspirational healthcare system that they felt was actually responsive to their needs. It's about 5 points that they made. One, they wanted a long-term relationship with a primary care provider, someone who would listen patiently and get to know them. Given the complexity of the healthcare and social service system, as well as the complexity of their own needs, they really valued the idea of having a navigator or coordinator who could help them manage their needs. They welcomed a broader conversation with their primary care physician or provider that's not just focused on their medical treatment, but looked at them as a whole person. It really resonated with them the concept of a one-stop shop where they could receive a wide variety of services under one roof, including primary care services, mental health treatment, counseling, and social services. And they hoped for a physician or provider who was culturally sensitive and who was able to relate to their own experiences. And I'll give you a pretty good example that we've had with one of our partners on the ground, and that was in the state of Pennsylvania. State of Pennsylvania had really achieved remarkable results by supporting meaningful consumer engagement and developing the state's community health choice program. And that's a mandatory managed care program for duly eligible persons for their long-term services needs. What they had done in the program was they partnered with the consumers in the community in response to feedback for Medicaid-only enrollees. The state had removed the requirement that MCOs list primary care physicians on the membership card. Prior to that, the Medicaid-only enrollees were receiving cards with a randomly assigned primary care physician listed, which really doesn't say a whole lot about choice. But while it was convenient for the MCOs to have a chosen physician's name, it caused widespread confusion for these communities. So changing this practice actually helped to better align the program with the needs of the community, rather than aligning the needs with those of the health plans. So in summary, even with the coverage gains, consumers really still face affordability barriers to access in primary care. Consumers can't find access to a primary care physician or provider. And when consumers can access primary care, they often can't find any that actually meet all of their needs. And there are significant disparities in the quality of the care that patients receive. So the first step in successfully advocating for a primary care system that meets the needs of the community is to articulate a positive vision of what that would look like. Just a few things to add to those are, patients are able to access primary care services in their community, and that's regardless of income, insurance status, or immigration status. Access to primary care is both affordable and timely. Care is comprehensive, high quality, and longitudinal. Providers are able to focus on delivering care to patients with a minimum of red tape or administrative burden. And financing of our primary care is substantial and reflects the importance and values of primary care in the health system. So thank you, and I'll pass it on to our next panelist.
So Anne, should I just dive right in? All right, I'll go. So thanks for having me. I really appreciate the opportunity to speak, and I'm so pleased to be on this panel with Brandon. I think that what we're talking about ties in well together. So my focus is around addressing ways the healthcare workforce can be engaged and empowered to help strengthen primary care. In early 2020, ACP, American College of Physicians, released a series of papers outlining a vision for healthcare in the United States that laid out a number of ways that this could happen. One key element of our new vision focused on payment delivery system reform, which I know you all have been talking about as well. Specifically, we called out a few things, that it's critically important that primary care physicians and their care teams identify strategies and be able to partner with patients and their caregivers to empower patients to be at the center of their care. Building on that, then, delivery and payment must be redesigned to support team-based care delivery models, including the patient, but it should vary in their approaches, though, in terms of how much risk is required for the practices. Not all practices are really ready and able to take on significant risk up front. I know that was discussed in the NASM paper as well. Payers also need to prioritize the inclusion of underserved patient populations and the care teams that serve them within their models. And payment needs to be substantially increased for primary care, commensurate with the value that it offers. I know Brandon spoke about that toward the end of his remarks as well, because the value, it offers significantly improved outcomes and reduced costs over time, and we know that that's what the data show. As important as payment is, though, it's the need to reduce an unnecessary administrative burden is equally important, particularly related to the many inefficient, ineffective billing and reporting requirements that are largely tied to our fee-for-service system. These types of requirements need to be eliminated in exchange for holding physicians and their care teams accountable for quality and cost outcomes. However, with regard to quality and cost outcomes, measures really do need to be more limited and patient-centered, actionable, appropriately attributed, and evidence-based. And we're really not there yet. This is work that's ongoing. They need to be meaningful and not simply check the box burdens for those physicians and their care teams that are engaged in this care. Building on that, health IT also needs to be evolved to prioritize the needs of patients and their care teams by removing a lot of non-value added interactions that take place today. Building on the importance of team-based care delivery, an example of where it's critically important, and I know this has been discussed as well today and I believe yesterday as well, is providing behavioral health services in an integrated fashion with primary care. Drug overdose deaths hit record high levels amid the pandemic. Rates of depression and anxiety grew 5.1% during the earlier days of the virus. The Surgeon General has sounded the alarm about a crisis in youth mental health. Fortunately, though, the Biden administration and Congress have identified this as an issue, and it seems promising that some new legislation will move forward in the coming year. The legislation and other policies we're hoping will move forward will include things like investment in evidence-based community mental health services, research on new delivery models, parity in mental and physical health benefits, and, as I mentioned earlier, integration of behavioral health and primary care. Another aspect that's really important here is multi-stakeholder involvement, not only to addressing the issues of mental and behavioral health, but also broader payment and delivery system issues. And groups like the Primary Care Collaborative, where Anne Greiner represents, and others can help ensure that these critical stakeholders are at the table. The Primary Care Collaborative has developed a set of shared principles of primary care that have guided their efforts over the past several years. And they're soon launching a new campaign to strengthen primary care, really building on the NASM report. Primary Care for America is another effort involving organizations to elevate the conversation around the importance of primary care. And ACP, we engaged in an effort with several other societies as well as with our board to develop a vision for primary care financing that's focused on offering care that achieves better health, seamless integration of care, health equity, and lower costs. Finally, I think it's really important to mention the importance of the well-being and professional fulfillment support for clinicians on the front line. Physicians have a very high rate of suicide, with roughly one doctor dying every day. This is nearly double the rate of the general population. This is why laws such as the recently enacted Lorna Breen Act are so important, and there are others currently under consideration in Congress. We're going to have a stable workforce within primary care, we have to support the clinicians providing that care. We just simply can't move forward if we don't address their needs, particularly as we've seen the worsening of this issue throughout the coronavirus epidemic or pandemic. So I'll stop there and leave it open for questions.
Thanks so much, Brandon and Sherry. And please, folks, put your questions in the chat. We want to have a lively conversation with both Brandon and Sherry. I'll kick things off by just noting how much convergence there is between Brandon and Sherry's remarks. I mean, I think first, you both acknowledge that our health system doesn't do as good a job as it could. And in fact, Brandon, your ratings of hardly ever or never addresses my needs are wow. We need to do a heck of a lot better, and that's underscored even more for patients from Black and Brown communities, those that are economically disadvantaged, rural health, et cetera. So, I think collectively we need to be reaching out and understanding what patients desire in our health system. I do want to underscore some of the resources that Brandon lifted up. I use all the time the focus group reports that you all did on what patients are looking for from more marginalized communities with respect to primary care. I would say that a lot of what those patients are looking for are what all patients are looking for, and frankly, are not finding often enough. So thank you very much, both of you, for underscoring the importance. ACP's policy is very clear that we need to get the patient voice and input into our thinking about care delivery and payment changes. The second point that you both made is, I think you share a common vision for what we want to achieve. And many of the things that you described, team-based care, comprehensive set of services, whole person care, including behavioral health integration, a partner with patients to navigate the system and to help guide them. These are actually all things that are in the PCC's shared principles, which were developed by about 100 organizations coming together. So I think we know what we need to do in terms of getting patient input. We have a vision, and now we need to get to work. So my first question to you both is, what's standing in our way of realizing this vision? What do you think our biggest barriers are? Brandon, would you like to take that question first?
Sure. Thank you for fielding that question. I think one, I'll respond in three parts. I think first, the system is doing exactly what it's designed to do. So conceptually, I think we actually can probably think a little bit bolder and move beyond strengthening the public health system or the primary care system to, in some senses, really re-envisioning how it may be transformed. I think patient-centeredness is still a pretty novel concept in a market or profit-driven system. I think many are still trying to figure out how to operationalize this, but we still see patients as consumers or customers of a product or service rather than partners in their own care in the delivery system. Thirdly, I think the healthcare system itself, or lack thereof, operates in silos, and this makes it more difficult for patients as well as for physicians alike. And there's so many touch points. I think a lot of time we focus exclusively on HHS with CMS, with Medicaid, Medicare, but of course there's also employers, there's schools, there's the VA, and TRICARE that we often leave out of these conversations. And all of these are impacted by so much, and we've seen bottlenecks in the supply chains, including the workforce, such as Sherry's mentioned, from COVID-19 that's disproportionately impacted safety net providers and low-income and minority communities, who are also likely going to see more of those with sanctions and trade wars, particularly for those who do not diversify their supply chain. In a profit-driven system, we see a lot of hospitals and provider mergers that eliminate community hospitals. and practices, particularly those in low-income and rural communities. So those are all the three main barriers that I see currently that can really get in the way of us coming to a shared vision.
Sherry, would you like to weigh in?
Sure. Well, I agree with everything Brandon just said. So I think what I would say, I spoke a lot about the importance of increasing payment for primary care, as well as moving into delivery and payment models that move us away from fee-for-service. Those are critical issues, and the system is not, we're not there yet. But beyond that, and I think building perhaps on what Brandon was saying is, there, and we saw this very clearly throughout the pandemic, there is no connection really between what's happening in primary care practices, what's available in terms of community services, or limited, I should say, and what's happening in the public health system. Right now, you know, if you think about a physician within a practice or a clinician within a practice, they have no real means or ability in many areas of the country to connect directly their patients with those services or with the public health system, or receive information back from those services or the public health system. And so, you know, that we have to find a way to fund that too, to provide resources so that those connections can be made, and that those community services and the public health system, as well as the primary care practice, can truly have the resources they need to operate together to provide that type of care to the patient population. This is relevant for everyone, but it certainly is particularly relevant for patient populations that are underserved now. You know, there's just, I think we saw this so much throughout the pandemic, where, you know, you just had to go where you could go to get care, because there wasn't, you know, in terms of even testing or vaccinations, et cetera, because it's so important to move this stuff fast to be able to protect the population from the virus, but even beyond that, to be able to provide care for those that have multiple chronic conditions that are trying to manage that, and it's in the midst of a pandemic. How are they supposed to get the food they need to be able to maintain a healthy lifestyle at all, if there's no way for them to really have those connections made, or help those connections be maintained throughout the pandemic? So I think that's a huge barrier that we need to address. I'll stop there, because I think there are other questions coming in.
There are. Thanks so much. But I think you both have pointed out that we have tremendous fragmentation in our system, and our payment structures don't move us towards integration. In fact, they move us further away. And this really came to roost when we were in the pandemic situation, and you know, we don't have data systems that talk to each other, and we don't have ways to share resources. We don't have ways to redirect patients to other settings and services. And so, you know, our lack of coordination and integration, and, you know, going in the poor health status of Americans. I mean, all of these things and many others contributed to our dismal outcomes when it came to COVID. A question that came in is about payment and measurement, and clearly, you know, we're so far from where we need to be. But the question is, you know, how do we pay for good outcomes for whole person, whole family care that is supported by teams, where primary care is a part of this, but it's not all of it. We don't, I think, envision primary care, you know, taking on all these community-based services, for example. So how do we figure out that payment model that is going to force integration and coordination when, you know, we do have these separate structures? Any thoughts about a response to this question?
Sure, I'll start and see if Sherry have anything to add. I think we are, in the process of still getting a lot of the data and evaluation results back from CMMI's Accountable Health Communities model, which was really good in trying to test if we address social determinants at certain care sites, and primary care sites was one of those, if there would be a clinical effect while also reducing healthcare expenditures. So that one, the reason why I highlighted that model, because one, primary care sites were included. It was holistic in its approach. It also included, at least for one arm of the study, community panels, which included state Medicaid agencies as well as consumers on some of these panels of boards. So I think it's a really good test on how we can move the needle and get further along. The second thing, which probably maybe even more important, is finding the political will for CMS and others alike to test models that also include prevention. Because unless we can get to those, or we think we can get ROI beyond the term limits of any political administration, I think it's going to be difficult to move that needle. So I think that's probably one of the number one things that we can do is to develop a business case for any given administration to take upon models that ROI may be seen in another administration.
Thank you for that, Brendan. And I think, really applaud CMMI's efforts to address some of these issues, particularly with their new ACO REACH program. And the timeframes under which they're working, are short. And you're mentioning even a shorter timeframe potentially, in terms of a political cycle. So that does present a set of challenges when we're talking about preventive care, which longer term we see, positive effects. Lloyd Mitchner, who has done so much work to integrate primary care and public health, has asked a question, and so appreciate, Lloyd, all of your work about how do we really engage communities in these efforts. And what is the role of primary care in engaging those communities to move forward in terms of, addressing inequities and impacting our health? It's not just in the medical office, as we well know.
Sure, I'll go again. The one, I think there's a whole spectrum of how do we engage communities. I think the first thing is we meet communities where they are. And that's really from the patient level as well as the other sectors who provide resources to those communities, such as community-based organizations. I think often we make the mistake in a term I'm going to use in healthifying all of the information and services and communications, expecting, I think, communities, patients, and other providers to all regress to the mean, I would say, of our own healthified language. So I think speaking in plain language helps in meeting folks where they are. I think being proactive in reaching out to communities. I think culturally competent care is also being cognizant of health literacy are all really good strategies. But I think we should also move beyond community engagement and really start moving towards community empowerment and patient empowerment that way, and breaking down power structures so that they really can be full agents and full partners in their own healthcare and decision making.
Yeah, and just to add on to that, I know we're very short on time, but I think one key thing that I think what happens now is that there's no means of having that happen. And so within the physician practice, then they are asked to often be the data collectors, be the information sharers, be the ones that, and that's just not a sustainable model for that to happen. I mentioned administrative burden being equally problematic as payment is. That's what happens. It lands on those practices to do that. And so we have to do this evolution of the system in a way that that puts the appropriate amount of responsibility on the practice, but does not in any way make them have to take on extra because nobody else can do it. There's no other way to do it. We need to figure out better and more innovative ways to be able to have that load shared, and so that the patient gets the appropriate care within the practice, but beyond that, but without putting all of that burden on the practice itself to have to be that resource for all of the information.
Thank you so much. And we are going to have to wrap. And I guess I would just close by saying, I don't think we can expect primary care to take on, a much more comprehensive set of services and address, some of these social vulnerabilities when we're investing 5% on the dollar. I mean, that just doesn't square. So, we're interested and excited to change that dynamic, and so excited that so many groups are rallying around the NASM report recommendations to move them forward. Thank you for joining us for the panel, and I think back over to Bob.
Thanks, Anne, so much. And I think I'm actually turning it over to Dr. Judy Steinberg.
Yes, thank you. And thank you so much for these great presentations. I'm Judith Steinberg. I am a senior advisor to the Assistant Secretary for Health, and I'm leading the initiative to strengthen primary health care. Now it is my great honor and pleasure to introduce Deputy Secretary Palm. Andrea Palm is the Deputy Secretary of the U.S. Department of Health and Human Services, and as Deputy Secretary, she is the Chief Operating Officer and responsible for overseeing the day-to-day operations of the department. She comes to the U.S. Department of Health and Human Services after having served as the Secretary Designee of the Department of Health Services in Wisconsin, a member of the Governor's Cabinet. She served in the Obama administration in a number of leadership roles in the U.S. Department of Health and Human Services, including acting Assistant Secretary for Legislation, Counselor, Chief of Staff, and Senior Counselor to the Secretary. And during her 8 years of tenure, she worked on administration priorities, including the Affordable Care Act, as well as providing leadership in the department's work to combat the opioid epidemic. Please join me in welcoming Deputy Secretary Palm.
Very good. Thank you so much, Dr. Steinberg, for that very kind introduction. I always I'm tempted to look over my shoulder to see who you're talking about when you give that introduction. And I really want to thank the National Academies of Sciences, Engineering, and Medicine for inviting me today to join this webinar. Some of the most important relationships we have in our lives are the ones we maintain with our primary care providers. They're not just doctors and health professionals, but in many regards, they're our confidants and trusted messengers. Primary care is the heart of our healthcare system. It provides people the opportunity to share their goals for health and wellness with a professional and someone that we can trust. That's why having a strong primary healthcare foundation, it's important to all of us, and it's really why we're all here today. So that's why I think you've heard throughout the webinar that at the Department of Health and Human Services, we're committed to working towards this end. And it's also why it's really my pleasure to be here with you today. But the foundation of our healthcare system has really long been under-resourced and unable to reach its full potential. Primary healthcare practices, like many other industries in this country, face economic hardship. I heard you talking about that very clearly in the panel discussion and the Q&A in the last section of this webinar. A recent study found that a decrease in patient visits during COVID-19 directly resulted in decreased revenues, which in turn has resulted in workforce reductions. Added to that, the well-being of our workforce itself has worsened during this time. And worst of all, many people continue to lack access to primary care due to expense, geographic location, and as I mentioned, workforce shortages. For these reasons, in the last year, the Biden-Harris administration has worked diligently to strengthen primary health care. We've prioritized expanding the Affordable Care Act, whose 12th anniversary we celebrate today, so that families don't have to choose between seeing a primary care provider and keeping the lights on. As of January 27th, a record 14.5 million people enrolled in quality healthcare coverage through the federal and state-based marketplaces, including nearly 6 million who newly enrolled in coverage this year. The American Rescue Plan and the ACA have made it possible for those who for too long have been unable to access quality healthcare due to cost to finally know what it feels like to see a doctor or health professional without worry of financial hardship. In addition, over the course of the pandemic, Medicaid and the Children's Health Insurance Program enrollment grew 14%, from 71 million to roughly 83 million people, the largest single increase in the program's history. These are historic numbers, but more than numbers, these are families who can now see a primary healthcare provider to meet their healthcare needs. We've also invested in our health centers. They're our nation's safety nets for comprehensive primary health care. And we've done that in the order of around $7.6 billion from the American Rescue Plan. Federally funded health centers are integral to reducing disparities and improving the health of under-resourced and uninsured individuals. And they have proven vital to helping us vaccinate people during COVID-19. As of right now, our health centers have administered close to 20 million doses, with over 69% administered to racial and ethnic minority patients. And we've worked to expand telehealth, so we leave no one behind regardless of geographic location or other hurdles that can preclude a person from physically visiting their healthcare provider. Last May, we announced the availability of $14.2 million from the American Rescue Plan to expand mental health care access by integrating telehealth services into pediatric primary care. And in August, HHS made a $19 million investment to strengthen telehealth services in rural and underserved communities and expand telehealth innovation and quality nationwide. According to a recent report by the Office of the Inspector General, over 28 million Medicare beneficiaries used telehealth during the first year of the pandemic. This was more than 2 in 5 Medicare beneficiaries. In total, our beneficiaries used 88 times more telehealth services during the first year of the pandemic than they used in the year previous to the pandemic. We'll use these lessons from COVID-19 to help ensure access to telehealth even after the public health emergency ends. But our work doesn't end with the patient, because we recognize that our healthcare workforce deserves not just our gratitude, but our help. In January, we announced $103 million to strengthen effective long-term efforts to enhance the well-being of healthcare workers, including their mental health and wellness. The funds secured through the American Rescue Plan will be dispersed to 45 organizations that oversee evidence-informed programs and practices, as well as training, with a focus on supporting providers in underserved and rural communities. And those funds build on other support this administration has provided to our healthcare providers throughout this pandemic, including the approximately $28.5 million in American Rescue Plan funding to create a new accredited primary care residency program in rural and underserved communities. In all, HHS's commitment is most directly demonstrated by the launch of the Initiative to Strengthen Primary Health Care, which we launched in September of 2021, and which you heard Dr. Steinberg mention in her opening introduction. The initiative is coordinated by our Office of the Assistant Secretary for Health, and it aims to optimize the use of our federal levers to achieve a foundation for strengthened primary health care. Secretary Becerra and I expect that this initiative will meaningfully address pivotal changes in each of the domains of the NASM implementing high-quality primary care report: payment, access, workforce, digital health, primary care research, and accountability. These actions will build on our current activities and put us on a path to strengthened primary health care. But this effort will certainly require all of us. As we work at the federal level, you must work at your levels using your levers. For today's webinar, more than 1,000 people registered to attend, including from patient, family, community advocacy organizations, state, local, territorial, and tribal governments, academia, healthcare payers, purchasers, providers and systems, philanthropic organizations, and others. I hope all of you will continue to collaborate with each other and with us, because as this pandemic has acutely demonstrated, when it comes to health and well-being, we are all in this together. In closing, primary healthcare needs to be affordable and easily accessible in the community, available to people where they live and work, and through multiple modalities, including telehealth. Primary healthcare provides people the opportunity to share their goals for health and wellness and work with their primary care team to develop and implement a personalized care plan. And this plan requires understanding who that person is and the context in which they live. It requires a holistic approach to care and coordination of care across healthcare as well as community settings. And holistic care means integrating services such as behavioral health and oral health with primary care so that people can easily access the services that they need. In addition to preventing illness and managing chronic diseases to improve health and well-being, primary healthcare providers can partner with communities and community organizations to help address the social determinants of health. To accomplish all of this, care must be provided by a multidisciplinary team and a diverse, culturally competent, and well-trained workforce with adequate numbers and geographic distribution to meet people's needs. Over the last 2 days, we've heard what is needed from primary care, what the model should look like, how we should measure primary care, and what innovations can be put into place and scaled to address challenges. Let's take these with us to inform actions we can take together to strengthen primary care for all. Thanks so much again for having me today.
Well, thank you, Deputy Secretary Palm, for your commitment to strengthening primary health care and your inspiring words. It's clear that you and the Department of Health and Human Services recognizes the necessity of having a strong primary health care foundation to reach our ultimate aims of improved health for our nation and improved health equity. So now, as I did yesterday, I will attempt, but it will be very difficult, to summarize in 5 minutes the key takeaways from the excellent presentations and discussions in today's webinar. We focused today's webinar on the innovations that are happening across our country in states, territories, and tribal nations. These are the laboratories for what could be done in other states and at the federal level. And first, I want to highlight that Maryland's primary care program, a multi-payer program, has saved lives during the COVID-19 pandemic. There it is, the evidence of the impact of strong primary health care on the pressing issues of our day, just a pandemic. So key themes that I heard were the need for state leadership and for convenings of broad coalitions and collaboratives, often with accountability to the state. And here are some examples. The Primary Care Investment Coordinating Group in California, a required primary care spending report to the legislature in Oregon on primary care spending in health plans and CCOs, a primary care payment reform collaborative in Oregon, convening a broad coalition in California to scale an effective model of primary care and standardizing a parsimonious measure set and hybrid payment model, as well as the attributes of care delivery. The South Carolina Collaborative on Telehealth and state offices for value-based care, which are requiring, in certain cases, a certain percentage on primary care investment. Also, a key theme was the importance of true and effective community engagement and really empowerment, as well as partnership with public health. And here are some examples. The community ownership and focus of South Central Foundation, community involvement in Practice-Based Research Network and the National Center for Primary Care at Morehouse. There was a great slide on key elements in building effective collaborations between primary care and public health. We should look at this. Using public health data to target interventions to improve health, interventions that are conducted in partnership with primary care practices. And Pennsylvania's Community Choice Program, designed with input from the community. And then there were other key innovations to highlight. a risk adjustment model that's used to allocate resources to practices to help address patients' social determinants of health. That's in Maryland. Flowing down the capitation dollars and incentives to practices to strengthen the investment in their network and population health in Massachusetts. The Flexible Services Program, a fantastic evidence-based innovation made at the state level for ACOs to use to get social services resources to patients and families. Meaningful and parsimonious measure sets, fully cross-generational care, and the increased use of synchronous and asynchronous virtual interactions between patients and providers so that they can reduce the need for in-person visits. And lastly, here are some great statements. Public health and primary care were born of the same mother, separated for a time, and now rejoined. And also, this is about pulling resources to where people are and delivering services on their terms. The owners of the systems, the consumers, drive the design. So, in summary, for the initiative to strengthen primary health care, these actions that we will be taking will be at the federal level, building on the expanse of activities that you just heard Deputy Secretary Palm discussed, the activities that the federal agencies and departments have already put into place or are planning for the coming year, and so to strengthen primary health care. The initiative has just completed this exercise, assessing the current state, and now we will be considering some pivotal actions to be taken on for an initial HHS plan guided by the NASEM report. And as Admiral Levine noted yesterday, we intend those actions to include setting up the infrastructure in HHS to continue its leadership role in overseeing the strengthening of primary health care to ensure high quality primary health care for all. And this includes the infrastructure to ensure ongoing community and stakeholder engagement in this effort. So these have been an incredible 2 days of learning. The webinar series provided a lot of information for us now to delve more deeply into as we consider the actions to be taken. Thank you to the speakers, moderators, and our audience members for their wonderful and inspiring discussions that we've had over the last 2 days. And thanks to NASEM for a fantastically organized event. I can't say enough about that. Now I'll turn the podium over, so to speak, to Bob Phillips for closing remarks from NASEM. Bob?
Judy, thank you so much. What another wonderful summary of the day. It really speaks to your faithful listening. Thank you so much.
Thank
you. To the group, the aim of the workshop, which just to remind you, was to inform the initiative to strengthen primary health care as it creates recommendations to the Secretary of Health and Human Services for a federal primary care council or office that coordinates primary care strategy in the service of our nation's healthcare priorities. I have to say, in my estimation, that was well met, and today was really a capstone to the great conversation yesterday. We were reminded throughout, and particularly in our last panel, that the well-being and future of our primary care clinicians is at stake at one end of the spectrum, and at the other, that there are shining examples of saving and improving lives that could be spread if we can coordinate primary care policy to do so. I'm grateful to the hundreds of you that joined our conversation these last 2 days. It was so heartening to see the numbers at the bottom of the screen throughout. Please know that this conversation continues, and we really hope that you are inspired to communicate to the Office of the Assistant Secretary for Health and to the National Academies about the importance of a federal primary care strategy and coordinating function. Specifically, why is it important to address the nation's healthcare priorities? Why is it important to that? Why is it important to supporting state, territorial, and tribal efforts? And where are those shining examples of high-functioning primary care that could be spread? So please continue the conversation and specifically put your ideas into the public domain, because that makes it even more valuable to informing the recommendations to the Secretary, which are expected in June. Like Judy, I want to thank our moderators and panelists for such a powerful conversation and lots of great ideas about how the Council, the office, could improve health equity and community resilience. Thank you to our Health and Human Services partners for listening. Certainly, Deputy Secretary Palm, thank you. Rear Admiral Levine yesterday for kicking this off, and particularly to Dr. Steinberg and McDevitt, but also the hundreds of you who joined the conversation today and yesterday. And finally, thank you to our National Academies partners, and particularly Francis Amankwa, Tochi Ogbu Mbadwa, Amechi Ukpabi, and Mark Meisner, and Dr. Cheryl Nass. This was put together so well. It made the conversation, frankly, almost seamless, and I really appreciate your efforts. Thank you all for joining.